Good morning, everyone. Greetings from AIIMS Delhi. It is my absolute privilege to welcome you all to this much-awaited update on the vesicoureteral reflux. This gathering brings together esteemed experts, clinicians, and researchers who have dedicated their lives to advancing pediatric urology and nephrology. Before we begin, we would like to extend our heartfelt gratitude to all our esteemed speakers, panelists, and attendees who have joined us today. Throughout this session, we'll be discussing critical aspects of VUR, from its pathophysiology and diagnosis to latest cutting-edge treatment modalities. We would have engaging presentations and thought-provoking discussions on the same. With that, let's officially commence this enlightening journey into the world of vesicoureteric reflux. To begin with, I would like to invite our Professor Dr. Sandeep Agarwala sir, our Head of Department at AIIMS, to commence the session and welcome our distinguished speakers.
Good morning, everybody. I'll just welcome you all here for this meeting on Sunday morning. Thank you for coming on this Sunday morning. We'll start. Already we are late. So I'll hand over the mic to Sugandha. Please start the proceedings. First speaker.
To begin our session, I would like to invite Dr. D.K. Yadav, the Additional Professor of Pediatric Surgery, to deliver his talk on anatomy, physiology, pathology of VU junction.
Respected teachers and my friends, it's my pleasure to present in front of Professor Prem Puri, Professor Mitra, Professor Bhatnagar, and other stalwarts. I will discuss in brief about the anatomy, pathology, and physiology of VUR. Actually, in VUR pathology, the vesicoureteric junction is a very crucial and critical structure. It's a chemical it's a chemical structure between the interaction of ureter and bladder. This is an interface between the high pressure zone and upper urinary tract low pressure zone. How the changes in the bladder with the time from the low pressure during the filling and the high pressure, how to prevent the reflux. This is because of the anatomy or because of the musculature arrangement or some other physiological process. It's not clearly known. But the crucial role of VUJ junction lies that it prevents the reflux. How it prevents? Overall treatment strategies. Our present scenario treatment is not totally based on the exact morphological anatomy and physiology. But some authors suggest that there is a role of musculature involvement, and some suggest no, this is purely a physiological process. But the VUR exact function as a gatekeeper. Usually in 50 to 60% cases of the VUR resolved by itself because of anatomical maturation, because of the other muscular changes in the urinary bladder wall and ureters, and some morphological changes in change of extracellular matrix. Now, whether this valvular mechanism is active, passive, or both, and there is role of muscle fibers, the sphincter may be true sphincter or physiological sphincter. There is also involvement of complex local neuronal network. This complex neuronal network start from the pelvis, go down along the ureter, and at the level of VUJ junction, where these nerves around by the side of the ureter and the pelvic plexus. So this determine how can we prevent the neural injury in the extravesical reimplantation. Usually the urinary bladder and ureter has 3 layers: outer longitudinal, inner mucosa, and the middle muscular layer. Usually the adventitia of ureter is mainly composed of fibroconnective tissue. This fibroconnective tissue usually act as a sheath. In this sheath, ureter usually like a sliding mechanism. Ureter slides in between this sheath of Waldeyer fascia of fibroconnective tissue. Usually, the muscle layer is the non-striated muscles, usually longitudinal fibers near the vesicoureteric junction. Near the vesicoureteric junction, there is absence of circular fibers. So, because of absence of circular fiber, there is no active peristalsis near the vesicoureteric junction. Now, various authors suggested the role of Bell's muscle around the vesicoureteric junction, these longitudinal fibers crossing other sides, and by the way of the trigone, they merge with some fiber of the urethra. The bladder, the four crucialia bladder they behave in different manner: detrusor muscle proper, trigone, vesicoureteric junction, and itself bladder neck. Usually in detrusor there is 3 layers, but in vesicoureteric junction the floor is formed by 2 muscles, outer longitudinal muscles and inner muscles, but roof is formed by 3 muscles. So because of these differences muscle layer, this act as a flap valve like mechanism. Usually in ureteric hiatus, when the ureter is enter in the bladder, outer hiatus and inner hiatus. Outer hiatus lies above the inner hiatus. So due to this, there is obliquity of the ureter entry into the bladder, and usually this entry in the bladder is at angle of 11 degree or little bit more. And the ureter course in the bladder is divided total intravesical course in 2 parts: intramural part and submucosal part. At the entry, when the ureters enter in the bladder, we can divide the ureteric entry into 2 parts: juxtavesical ureter and intravesical ureter. Usually, initially it was thought by the Ledbetter and Politano that there is no submucosal length in the newborn or in the fetus. But further research shows that by the 22 week of the life, the length of submucosal ureter started. Total intravesical ureter length is 0.5 centimeter at birth, and it's reached to adulthood by the age of 12 years to 1.5 to 2 centimeter. In the ratio of the intravesical length with the diameter of the ureter is usually 2.23 into 1, and in around 12 to 20 week of life, the ratio is between 1.2:1. Now the role of ureteric sheath. Usually this, as I told you, the ureteric sheath, this is formed of loose connective tissue, and whether this ureteric sheath is of ureter origin, bladder origin or dual origin, not clearly known. But it's clear that there is a telescopic action of ureter inside the sheath, and because of this telescopic action and the proximal ureter peristalsis, the urine flows inside the bladder. Now the behavior of the trigone. The trigone behavior is important for the overall competency of vesicoureteric junction. What happens when the trigone, there is some abnormality in the trigone may be placed laterally, and at the time of contraction, the bladder neck is pulled. This will cause reflux. Now, the Politano again emphasized that the intramuscular part of the ureter, outer diameter of the ureter, and total submucosal length has equitable distribution, and there is no differences in various age groups and sex. But now it is clear that vesicoureteric junction, there is a presence of musculature structure, and the peristaltic activity in the ureter is maybe neural, but mostly nowadays they said that the peristaltic activity of ureter is because of the muscles myogenic origin. The innervation, both sympathetic and parasympathetic innervation, and ureterotrigonal and vesical component have the same nerve supply. Now, the mucosa of the bladder has the activity for the acetylcholinesterase, while the mucosa of the ureter has the activity for the butyrylcholinesterase. In the distal part of the ureter, they are nNOS positive. Now the pelvic plexus. The pelvic plexus nerve travel more laterally and dorsal and cranial to the vesicoureteric junction. The bladder mucosa shows the activity for the they have the cholinergic innervation, while the outer part of the ureter shows the have the adrenergic innervation. Now, how the anti-reflux mechanism works? Thus, there are multiple theory for this. One important is the both muscular and neural integrity should be maintained. Another is the passive theory, because of the length of the submucosal length of the ureter, and active theories proposed. There is the longitudinal muscles near the vesicoureteral junction play a role, and because of the inherent tonic action of the urinary bladder. And mixed theory suppose both there is involvement of both sphincteric and ureteric obliquity. Now, this refluxing ureter in pathology shows the atrophy, dysplasia, and severe architectural disarrangement of the smooth muscles, and interstitial cells of Cahals are decreased or sometimes absent in distal part of the ureter. And metabolic changes show there is deposition of extracellular matrix, and usually there is hypoplasia of the vessels in the distal part of the ureter, and there is increased TNF alpha and TGF beta 1. The vascular marker like VEGF found less in cases of reflux ureter. These refluxing ureter lack peripheral nerve supply, and there is reduced number of intramural ganglionic cells. Because of this absence, the muscle function not act properly, and in most of the cases there is diminished ureteral perfusion. The electron microscopy of this distal end of the ureter shows distinct immunohistopathological changes, ultrastructural changes in the smooth muscle cells, and there is more vacuole formation in the distal part of the ureter. And the connexin 43, which is involved with intercellular signaling, is also absent. Because of the injection of the subtrigonal injection, there is response in form of inflammatory reaction with the giant cell types in around 80 to 100% of the cases. There is chronic periureteral inflammation in around 30% cases, and pseudocapsule formation. The incidence of pseudocapsule formation ranges from 10% to 43%. Now, the main important physiology, how this ureteric structure, how the urine propels from the ureter to the bladder, this depend upon the totally depend upon the inherent muscular activity inside the ureter. The ureteric wall structure is multi-directional and have enough tensile strength and capacity of recoiling. Smooth muscle sin and collagen fibril is responsible for this strength and recoiling. The higher tensile strength along the longitudinal axis of the ureter is responsible for urine flow. But the exact vesicoureteral junction or intrauterine ureter have no peristaltic activity because of the absence of the circular muscles. The manometry shows both decrease in Pmax and basal pressure, and there is because of the impaired basal pressure and ureteral arrhythmia. In most of the cases, around 60% of the cases shows the silent pressure profile. But depending upon this anatomy, musculature structure, neuronal structure, the electrical impulse started from the pelvis goes downwards. All these are anatomical and physiological changes. But our treatment philosophy totally depend upon our empirical basis. Now, how to some modifiable factor. The modifiable factor, how we can change the anatomy at the level of VUJ, and how we can prevent the injury if we are planning the extra triangular surgery. Thank you.
Thank you, sir, for sharing your insights on the topic. I would now like to invite Dr. Prabodh Goyal, sir, for sharing his presentation on bioinformatics in VUR.
A very good morning to all of you. And a sincere gratitude to our Honorable Director, sir, to our Chief Guest, Professor Prem Puri, our Head of Department, my seniors, teachers, and colleagues for making this gathering so meaningful and for including this topic in today's discussion. Well, this is something which is new, and most of us as surgeons, they tend to remain in the niche of the operating theaters and seldom find opportunities to dwell into this aspect of research. I'm fortunate that this topic figured in the first few lectures so that I can catch you all while you are still energetic and full of vigor. So I'll be talking about the role of bioinformatics or computational biology in vesicoureteric reflux. Starting from the very basics, we are all aware that we have the double-stranded DNA helix, which is composed of these codons and nucleotides, ATGC format. You can see they make up the genetic structure of the body, and analysis of this composition, analysis at the level of ATGCs is what we deal when I talk of bioinformatics or computational biology. So why is it important? So we all know that when we talk about vesicoureteric reflux, we have cases which are sporadic, but we do have cases which are familial. So familial recurrence is noted and is accepted in vesicoureteric reflux. In fact, 30 to 50% of siblings of affected children will have evidence of vesicoureteric reflux. So far, we have no concrete ideas about how this is inherited. So we say that it has a variable penetrance. Variable penetrance would mean that the same genotype can manifest differently in different individuals. So we know genes which are responsible, but doesn't mean that if the gene is present or a particular allele is present, it will always have the same effect on the individual. So we know that these are the 5 key genes which have been implicated in vesicoureteric reflux so far, and this observation is essentially a result of the bioinformatics studies. So this is the first gene, PAX2 gene, which is located on long arm of chromosome 10. It is a critical transcription factor for kidney and ureter development, and mutations are known to be associated with vesicoureteric reflux. The second gene is the ROBO2 gene on the short arm of chromosome 3. It regulates the outgrowth of the ureteric bud when the embryological development is taking place and the positioning of the ureteric bud. So obviously this is associated with vesicoureteric reflux. The third gene is the SOC17 gene, which is located on long arm of chromosome 8. It is involved in the development of endoderm and urogenital formation. So mutations of this gene are known to affect the differentiation of ureter or its proper insertion into the bladder. The fourth is the angiotensin 2 receptor type 2 gene. This is located on the X chromosome and regulates the development of smooth muscle in the urinary tract. So when there is an abnormality, please excuse me for my bad throat. Dysregulation would lead to abnormal ureteral peristalsis and uretrovesical junction integrity tissues. Professor Bajpayee sir, you walk in at the time when I'm talking of the angiotensin 2 receptor gene. Then the UPK3A gene, which called as the uroplakin gene. So uroplakin is a membrane protein which deals with the movement across urothelium. Again, abnormalities of this gene are associated with vesicoureteric reflux located on long arm of chromosome 22. So these are the 5 genes which are currently in vogue. There is a long list. There are many more. I'm sure you all must be having some more genes in mind which are relevant here. But my basic idea is to just take you through the journey of bioinformatics. So as of now, we have a lot of techniques which are available in bioinformatics. I've just tried to summarize here. So GWAS is genome-wide association studies. NGS is next generation sequencing. Then we do a pathway analysis, which helps us to identify biomarkers. We have system biology. We do a 3D modeling of the protein and understand how the molecules interact with each other. Together, they are called as structural bioinformatics. And now we have AI to harness the advantage of all these roles and put them into one. So I'll talk about them one by one. So first is genome-wide association studies. I think this is here we started our journey of bioinformatics. Technically, if we assume that we know the human genetic structure has 23 pairs of chromosomes, and we know that we have total of 25,000 genes, and there are 3.2 million base pairs. Now suppose we copy these base pairs and try to create a book of them, and this book runs into 23 volumes. I'm just trying to create an analogy which I'll be referring to at multiple places to help you understand what these individual terms mean. So technically, these 3.2 billion ATGCs which compose our nuclear structure, we have written down on paper, and we got them bound into 23 volumes of books. So each book is like a chromosome. Now each alphabet will be a single nucleotide, which can be A, T, G, and C. Now those alphabets will make up words. So these words will be like codons. Now, when we talk, so this is what the ATGCs look like. So when we talk of genome-wide association studies, what we are trying to do is that we will study the genetic structure of individuals and find out what alphabets have been replaced. What alphabets in the entire 23 volumes have been replaced. And now suppose you end up with a finding that there is a particular position at which a particular alphabet has been replaced more frequently in patients of vesicoureteric reflux as compared to normal individuals. So then you have an inkling that this mutation, this is what is called as a mutation or a single nucleotide polymorphism. And then you have the inkling that this mutation might be causing vesicoureteric reflux. So GWAS scans the entire genome of many individuals to find genetic variants which occur more frequently in people with a particular disease or a particular trait as compared to normal individuals. Now here we have a microarray technology. So microarray technology means a DNA chip which has those nucleotides details embedded on it. So GWAS has a limitation that it will not scan the entire genome. So we have already embedded the information into DNA chip that you check this and this locations. So it will check only those locations, but then it will tell you the prevalence of mutation between the study and the control group. So this is the flowchart of GWAS. You take the sample from the patient, do the genotyping with the help of the microarray technology, find out what are those mutations which are more common in patient with a disease or a trait, do a statistical analysis to find out if this is actually different between affected and unaffected population. These are the various software tools which you would be required while you're doing this part of the analysis. So next in line and probably the most widely used in today's times is whole exome sequencing. Now we know that the entire genomic structure is composed of 3.2 billion nucleotides which organize themselves into genes. Now ultimately how do the genes function? They function through translation into proteins. Now we know that of the entire genetic structure only 1% will translate into proteins while the other 99% is not. So when we are studying this 1% protein coding region of the genome, that is called as exome. 1% is exome, so you call it as whole exome sequencing. So when you do whole exome sequencing, you will have a linear list of ATGCs for those 1% of the coding region. So how is it different on GWAS? In GWAS, there was a limitation of which foci on the genetic structure would be studied. In whole exome, you will study the entire 1% of the genome which is translated into proteins. Contrarily, you have whole genome sequencing in which it will study all of them, irrespective of whether they are protein coding or protein non-coding. So whole exome is one part of next generation sequencing, high throughput sequencing. It targets the protein coding regions of the genome and helps you identify potentially rare variants. Another advantage is you can study in the family trios. Family trios means you study the proband and the parents. So when you know that this gene was heterozygous in the father, I'm just creating an example, heterozygous in the father and heterozygous in the mother, and the child has homozygous. So that gives you more evidence that this could be responsible. So these are the genes PAX2, ROBO2, SOC17 and UPK3A, which are known to be related to vesicoureteric reflux and have been identified through whole exome sequencing. So this I've already discussed. So this is what whole exome sequencing helps you. So like I tell you an example, a patient of spina bifida presenting with poor clinical profile, so which means hydrocephalus is there, bladder bowel are involved, lower limbs are weak. You operate the child, you counsel everything to the parents, and then the mother comes back to you and says, Dr. Saab, now this was our first child, we are going to have a second child. How likely is it that my second child will have the same problem? Same for VUR. A family is struggling with a child, a girl child. The first child is a girl child. She has VUR, which is a bad VUR. The kidneys have become scarred. The renal functions are falling. And now the family wants to have a second child. And they want to know what are the chances. VJ sir, please. That's mine. And the family wants to know what are the chances that this second baby will have a similar profile. So whole exome sequencing can give you this answer. Similarly, now the mother wants to know, okay, let's forget about the second child, but what are the chances that my child, when he has a family, this disease can go on to his children? So second pertinent question. Now the third question. Okay, Roxab, so you have told us that the disease is genetic and that is why my child has it, and you're telling that there are chances that his children may also have the disease. Can I do something about it to prevent it from being transferred? So if we know it is a gene which is responsible, we know it is recessive, then at the time of marriage, instead of matching the kundlis or as a supplement to kundlis, we can match the genotypes and tell them that the prospective spouse should not be harboring this particular gene. So the three pertinent questions, which, of course, if it is an arranged marriage, if you get that option to match these things. So it helps you in genetic counseling. Then you can have therapeutic applications. If you know the gene target, you can make appropriate drugs. It helps you in the understanding of disease mechanisms through molecular pathways and risk stratification. You can figure out that there are 5 genes which are associated with vesicoureteric reflux. When a child has either of these 2 genes, generally scars would not be there. But these 3 genes are more likely to end up in renal scarring and end-stage renal disease. That is what risk stratification is all about. So just an example of how whole exome sequencing has been helping us in understanding the different molecular aspects of vesicoureteric reflux. So a lot of genes and their implications. So the first paragraph is about identifying rare variants. Second is about novel genes. Third is understanding their role in syndromic associations. Then whole exome helps identify how the different molecular pathways are involved in the etiopathogenesis of VUR. And finally, the de novo mutations, which means that mutations which are not inherited from the parents. Now, the third important aspect is transcriptomics, what we call as RNA sequencing. So, coming back to the same book, now we have, say, for example, Harrison running into 23 volumes. Now, you have an example of, you have to appear for professional examinations. And now you're thinking, how do I finish Harrison? So, you know that these are the most important questions which have been asked in exam over the last 10 years. Or you have a list from your seniors that you read these chapters, you can ignore these chapters. These chapters are important or relevant. Similarly, we have 25,000 genes, but all of them may not be working at the same time, or all of them may not be working in the same individual. So you did a whole exome sequencing, you identified some genes which were wrong in the individual, but are those genes actually being expressed? There's something which is missing, but that doesn't mean it may be causing the disease. Or technically, whole exome was the anatomic part and transcriptomics is the functional part. So transcriptomics or RNA sequencing provides a dynamic view of gene expression patterns that complement genomic studies in VUR research. It compares the gene expression in the tissues obtained from the vesicoureteric junction in VUR patients vis-a-vis healthy controls. Then these days it has advanced to become single cell RNA sequencing. So you can catch hold of a cell of a particular type and then see if the gene is expressed in that or not. And finally, time course experiments. So there might be a gene which you find is altered and you study it is not expressed. But then there is a possibility it was expressed during embryonic development. So you can take tissues at different phases of development and see what genes are being expressed at what phases of life. So this is about the uretrovesical junction. We see that WNT pathway is involved primarily when ureteric bud is being formed. And then you have the GDNF RAT pathway, the smooth muscle differentiation, the extracellular matrix organization. So these are different aspects which now we know because we ventured into transcriptomics. So if it was not for transcriptomics, we would not have had so detailed information about the molecular pathways involved in vesico-ureteric reflux. So if you want to find out what are the uses of transcriptomics, so it can help you in finding out the genetic markers which could be different from primary VUR versus secondary VUR. Transcriptomics can help you identify biomarkers for disease, for VUR per se, for poor prognostic possibilities in VUR for renal scarring, for chances of being transmission, for the possibility if a particular gene will lead to severity and scarring. Then anti-inflammatory intervention. See, this is something which has come up very strongly in VUR. Now we know in children with vesico-ureteric reflux, all the inflammatory pathways are highly activated. And now people are trying to target VUR through anti-inflammatory drug molecules. So development of drug targets. Just another way to depict, so see, an RNA sequencing, you take a tissue from the vesico-ureteric reflux patient and you take the same tissue from a healthy patient, and then you can find the differences. So see, I have highlighted the inflammatory pathways here, which are new. We know there are developmental pathways involved. We know the pathways will lead to fibrosis and scarring, but the inflammatory pathways is something new and possibly hold the promise for the future. Next come to metabolomics. So metabolomics refers to the small molecule metabolites. Now, considering that you have a professional examination, you have a list of topics that you want to read in Harrison, you went over all those topics in the night. But how much did you actually retain in your mind when you were sitting for the exam? So that is what the metabolites are. So it is technically a functional readout of cellular processes that reflect both genetic factors and environmental influences. See, the translation of protein can also be affected by the epigenetic factors or environmental influences. So it will tell you about the organic acids, about the amino acids and other metabolites which are being produced by the action of those genes. So now say, I'll give an example here. Children with VUR who develop kidney scarring vis-a-vis normal individuals or children with VUR who don't develop scarring. You take a urine sample from these three groups, you analyze the urine sample for the small molecules, and you might find that there are some molecules which are associated when scarring is not there, or which are associated when it is likely to be associated with a bad quality of scarring. So ultimately, metabolomics is about identifying the candidates who will take a particular trajectory of what you call as creating biomarkers. So you can, these ultimately, suppose you believe that this particular patient of VUR is likely to develop scarring. So early in the course of scarring, you can catch hold of that patient through those metabolites, and maybe you can initiate more rigorous infection prevention methods early in the course of the disease. So metabolomics can help you develop non-invasive biomarkers. They can help you monitor the response to treatment if the level of those metabolites come down or rise or not. They can help you identify therapeutic targets for the disease. They help in risk stratification, and most important, creating a prediction model, because that is what we want to know. A new family comes to you, the child has VUR, and the parents are concerned what will be the future trajectory. So instead of teaching them the entire chapter that you have learned, you can look into the molecular biomarkers and give them a focused idea as to how this child is going to behave. Now, another dimension is proteomics. So you have given the exam, you have written all that you could remember. Now comes you join the internship and you are seeing your patients. Now, how much of it have you actually remembered? How much of it has stuck in your mind? That is the proteomics part. So proteomics deals with the large scale study of proteins and their functions. It provides a functional perspective. Ultimately, anything has to happen in the body. It is immaterial whether you have the gene or not. If it is not translated into proteins, it's not functioning. So that is what proteomics is all about, studying the differences in protein structure created by these mutations. So we know that proteins are sensitive indicators of tubular injury, and they are being used to identify patients at risk for progressive renal damage. Proteomics has also revealed dysregulated protein networks and pathways in VUR. We are aware of these terms, MMPs, matrix metalloproteinases, and tissue inhibitors of matrix metalloproteinases. So they have been developed through the use of proteomics here. Now these proteins also provide you with actionable targets, what you call as drug targets for action. Now, differential protein expression can help you differentiate between primary and secondary VUR. We know that the protein expression is different, and therefore the factors which will govern the trajectory of primary versus secondary VUR will be different. Finally, we have point of care proteomic assays which can help you in screening large populations or monitoring the response to treatment. Now, having done all these four aspects, the whole exome sequencing, the transcriptomics, metabolomics, and proteomics, you will have a lot of molecular information which computational biology can analyze and provide you with insights into the molecular mechanism which are happening. So they what you call as 3D protein modeling. We have the structure of the normal protein. Now, considering a particular mutation, if that mutation happens and if the gene is expressed, how will the resultant protein be different from the normal protein? Will a protein be actually formed or will it be terminated? If a protein is formed, will it have similar structure and function or will it be altered? Alternatively, is the molecule stable? Is it folding the same way that it should have been folding? Is it bringing about the same effects what was expected to be? So this is what structural biology is all about, when you analyze the protein structure and you predict the outcomes of that protein. So many times it happens when I do I've been doing this analysis in all sorts of congenital malformations. We end up finding a gene in whole exome sequencing. But when you ultimately reach the protein structure, you find that this is not altering the structure of protein at all. So when you do whole exome sequencing and you have, say, a cohort of 10 patients, you would realize that you have some list of 40-45 genetic markers which could be responsible. But when you do the protein modeling, you realize only 3 are actually causing change in the structure of protein. So you are more focused. That's why you use the term multi-omic study when you're doing all the things together. Now, once you have the protein structure, next step and the last step for today is molecular docking. So understanding how biomolecules interact with one another. So a protein is formed which is abnormal, but directly the function of protein is not affected. But it is possible when it interacts with the other proteins for a particular reaction, it may not interact in the same way. So in isolation, the function of this protein appears normal, but as a combination of 3 proteins, the effect that is expected doesn't happen together. So this is what molecular docking is all about. So say for example, this blue box is about a receptor and the red box is about a ligand. So now, once we know how this protein receptors are changed, we can identify the drug molecules to bring about required actions. So overall, it will help you in drug discovery, effects of mutation, signaling pathways, and repurposing. Ultimately, the bottom line is same for all these multi-omic studies. In fact, none of these works in isolation. It is a combination of these. But I think that's the pathway to go. And that offers the potential of personalized medicine. So you can treat your patient as a patient and don't treat all the patients of VUR as one box. Thank you very much.
Thank you, sir, for your insightful talk on bioinformatics and VUR. I would now like to invite Dr. J.K. Meena, Assistant Professor of Department of Pediatrics, to give a talk on current status of continuous antibiotic prophylaxis in VUR.
Thank you for the introduction. Good morning, everyone. At outset, would like to thank Professor Agarwal and organizing team for giving me this opportunity. So being trained at this institute is always, a privilege standing here and talk about one of my favorite topic in pediatric nephrology, that is continuous antibiotic prophylaxis in primary VUR. I would briefly talk about, what are the risk factors. So one of the main concern patients with VUR face is recurrent symptomatic UTIs. So this, Kaplan-Meier survivor curve from the QT and river cohort, which is chiefly North American patients, clearly showed that patients who have VUR compared to those patients who don't have VUR, there is a higher risk of developing symptomatic UTI. This data is from our own cohort, which is under publication, so that the patients who have symptomatic UTI before diagnosis tend to have repeated episodes of UTI in follow-up. Then from same cohort, we also shown that the patients who have high-grade VUR, they tend to have higher recurrence of symptomatic UTI compared to lower grade of VUR. And this pool data from 8 randomized control trials, which has been looked at the efficacy of antibiotic prophylaxis, clearly showed that patients who have dilating VUR tend to have higher symptomatic UTI, almost 2 to 2.7 times higher compared to non-dilating VUR. The other major important risk factor which is there for these patients to develop recurrence of UTI is bladder bowel dysfunction, and is now increasingly being recognized probably as important as primary VUR, that bladder bowel disorder is an important risk factor, and if you don't address this, then efficacy of antibiotic prophylaxis may not be good. So from river cohort, which is they have clearly showed that patients who have VUR and BBD both, they almost half of them would develop recurrence of UTI. Similar kind of thing we have shown in this pooled analysis, where we have shown that patients who have BBD and VUR combination, they almost 2 times higher risk of developing recurrence of UTI compared to those patients who don't have bladder bowel dysfunction. So over the last 3 decades and so, at least 10 different randomized control trials had looked at the antibacterial prophylaxis efficacy. And among those last 4 are, definitely are good placebo-controlled trials who have low risk of bias. So beginning from, international reflux study, which is chiefly looked at the combination of surgery plus antibiotic prophylaxis versus antibiotic prophylaxis. And there were other randomized control trials were, looked at the same combination versus antibiotic prophylaxis. So their pooled result clearly showed that there is, hardly any difference between 2 limbs in terms of UTI, even up to like 5 years of follow-up. The only different thing they could show that, the number of febrile UTIs were probably less when you have used combination of antibiotic prophylaxis and surgical reimplantation. So from there onward, and late 90s and early 2000s, antibiotic prophylaxis became kind of cornerstone for management of these patients on long-term follow-up. Following that, multiple randomized control trials have looked at the efficacy of antibiotic prophylaxis in more robust way. One of them was Swedish reflux trial, which looked at the endoscopic therapy versus antibiotic prophylaxis versus just observing surveillance. So the Swedish reflux trial did show that there is benefit in girls, where compared to surveillance, antibiotic prophylaxis and endoscopic therapy do prevent risk of recurrence, but in boys there was hardly any difference. One of the major problems is Swedish reflux trial, that they have used bag specimen for defining UTI, which may be at higher risk of contamination. Next big trial came from Australia, the PREVENT trial, in which they looked at patient less than 18 years of age with VUR grade 1 to 4 and without VUR as well. And they have used Sepran prophylaxis over 1 year, and they clearly showed that patients with Sepran prophylaxis tend to have less recurrence of symptomatic UTI compared to placebo. The probably largest trial conducted till now on vesicoureteral reflux on antibacterial efficacy was VUR from North America, which chiefly looked at the patients who had lower grade of VUR, predominantly and girls. And they also showed that almost 50% difference in antibiotic prophylaxis compared to placebo. And 2 important aspects which they have also highlighted, that patients who had bladder bowel dysfunction and initial febrile UTI probably have more efficacy in terms of preventing UTIs, although there was no difference in terms of kidney scarring related to UTI. Almost similar time when the PREVENT and REVOR trial was ongoing, and our department, Professor Pankaj Hari and team led this randomized control trial, in which they also used subtrans prophylaxis. Although the number of patients were less, but compared to the REVOR trial, this randomized control trial had chiefly boys with high grade of reflux, and we could not find the, in fact, there was higher risk of UTI in patients who have antibiotic prophylaxis, and there was increased risk of bacterial resistance in these patients. So Cochrane group looked at the, all these randomized control trials all together, and in 2019 they finally concluded that there is, very little or no benefit when we compared antibiotic prophylaxis versus no prophylaxis on all group of the patients. So the latest trial which has, looked at this, and this is chiefly, looking at the patients who are antenatally detected hydronephrosis and diagnosed in infancy as a vesicoureteral reflux, PREDICT trial from Europe and multicentric trial, and they chiefly included patients who have grade 2 to 4 vesicoureteral reflux, and they have used a various different kind of antibacterial therapy. So before that, all randomized control trial used, one single antibiotic for prophylaxis. So in this trial, the choice of antibiotic were left to physicians, whether it's Septran, amoxiclav, or nitrofurantoin. So in this, author did show that there is a significant difference. So patients who have received antibiotic prophylaxis, almost 45% reduction in development of the symptomatic UTI. So when we were updating our guideline on UTI and vesicoureteral reflux in 22-23, we kind of looked at, various subgroup, whether there are any difference in terms of gender, whether males are boys versus girls, or age group wise, or then we find one significant difference, that patients who have just high grade VUR, so we dissected out data, there is definitely, benefit when we are using antibiotic prophylaxis, so almost 30% reduction in patients who have high grade VUR compared to low grade VUR. So we didn't find any significant difference in terms of reduction in symptomatic UTI in patients who have high grade VUR and receiving antibiotic prophylaxis. So other important aspect of these patients with vesicoureteral reflux have worsening of the kidney scarring or UTI related kidney scarring. So pooled data from these randomized control trial don't show that, doesn't find any efficacy of antibiotic prophylaxis in preventing kidney scarring, although none of these, trial individually were, have enough sample size to look at this answer, but the pool prevalence also, pool data also don't show anything. The one of the major concern, currently there globally is antimicrobial resistance. And the randomized control side clearly show that if you are using antibiotic prophylaxis, there is a definitely increased risk of UTI with uropathogens who are multi-drug resistance. So do we have anything additional? So probably there is some preliminary data from, small 2-3 trials that antibiotic, cranberry products may be effective, but we need, larger randomized control trial to look at this product or this intervention. We did try, 1.5 year back, but we couldn't succeed in getting, securing funding. So we'll probably maybe looking at this question in sometime in future. So based on this evidence, our recently revised guideline clearly say that you can use antibiotic prophylaxis in children who have febrile UTI in only high grade VUR. We don't recommend it for low grade VUR. Choice of antibiotic prophylaxis is cotrimoxazole or nitrofurantoin in kids older than 6 months. For younger kids, we would prefer cephalexin. And we would definitely not use antibiotic prophylaxis in kids who are awaiting, diagnostic evaluation, because even in all like high grade VUR, there is limited efficacy. So there's no point of giving antibiotic prophylaxis to all kids who have been diagnosed have antenatal hydronephrosis. So this is our final algorithm. What we currently recommend, that if you have high grade VUR, look for bladder bowel dysfunction and give antibiotic prophylaxis to these patients. Low grade VUR we don't recommend unless there is bladder bowel dysfunction simultaneously there. So other major concern in terms of antimicrobial resistance, that earlier guideline used to recommend that you give it for 5 years or longer or so. But what currently we have done, that we have kind of looked at the literature and we kind of limited the use of antibiotic prophylaxis duration. So if patients had achieved toilet training and there is no evidence of bladder bowel dysfunction and there is no recurrence of UTI in last 1 year, we would consider stopping antibiotic prophylaxis in these patients irrespective of their age. So that would probably limit the use of antibiotic prophylaxis. So what do international guidelines currently say about the long-term low-dose antibiotic prophylaxis? So NICE is almost now 10 years old. So American Academy of Pediatrics clearly said that there is no role of antibiotic prophylaxis. Italian guidelines say that you can use in high grade. Again, Japanese and Swiss guideline almost on similar page, that you can use it in high grade vesicouretic reflux. And the latest European Association of Urology or European Society of Pediatric Urology say that you can use in low grade in less than 1 year infants, and in high grade VUR you can use till there is a presence of bladder bowel dysfunction. So based on this, world is probably moving from universal antibiotic prophylaxis and VUR to a selective group of patients who are at high risk of developing UTI. Thank you for the patient list.
Dr. Meena, can I ask you a question? There's a lot of literature coming out now about gut microbiota
Yes, sir.
changes in patients who are getting CAP. Any?
So there is some data, that's why there is a role that we use. You should use narrow spectrum antibiotic rather than broad spectrum antibiotic of augmentin or cefixime. So that's why we say that you should use Septran and nitrofurantoin rather than using broad spectrum antibiotic which can alter your gut microbiota. So there are some recent studies which does suggest that if you are using for long term, there would be alteration of the gut microbiota probably, but we need larger data, and that's probably one of the reasons. That's why we have kind of tried to restrict the duration of antibiotic prophylaxis use.
Thank you, sir, for sharing your insights with us. We'll now continue our session after a short tea break, and refreshments are arranged outside the meeting room. Thank you. As we go ahead with the session, I encourage you all to actively participate, ask questions, and share your insights. This program is not just about learning, it's about collaboration, innovation, and collectively working towards better patient care. I would now like to invite Dr. Pankaj Hari sir, HOD in Pediatrics, on the dais for their talk on long-term outcomes of primary VUR. Thank you, sir.
Thank you very much. I would like to congratulate the Department of Pediatric Surgery for organizing this focused update on vesicouretic reflux, and asking Department of Pediatrics to also join in. So I'll be talking about long-term outcomes of primary VUR. It's not moving. So, yeah. So primary VUR, the exact prevalence is not very clear, and most of the reviews would mention a figure of about 1%. But if you look at truly VUR in well children, and of course this is now no more done, previously studies in 1960s and 70s would report a prevalence of VUR in asymptomatic healthy newborns to be as much as 10 to 15%. So it's a far more common condition. But the important thing to realize is that this condition is self-resolving. However, it is associated with renal damage, and that is the one that determines the long-term outcomes of these patients. So most of the patients of VUR are picked up after a UTI, and almost 30 to 40% of children who have UTI, if you investigate them, will have a primary VUR. And there is an association between VUR and end-stage kidney disease to the tune of 7 to 17% in various registries of chronic kidney disease. And we heard that there is a familial clustering of VUR in the morning, and there has to be a genetic basis for this condition. However, and there is a syndromic association. However, when we try to look at the monogenic genes associated with VUR, they are very few. So a very small number of patients will be picked up to have a monogenic cause of VUR, and most of the VUR or primary VUR is very, very heterogeneous. And trying to find out what is the genetic basis of VUR, we also did a study with the Institute of Genomics and Integrative Biology, and it was very, very odd that we didn't find any of these genes, the PAX2, the ROBO as a cause of VUR in our patients. And perhaps it now appears that the non-coding regulatory regions are likely contributors for VUR, and therefore, again, longer research is needed to find out what is the exact basis of VUR. There is an association of VUR with bladder bowel dysfunction, which even Jitendra also mentioned, and this results in recurrent UTI in these children. The meta-analysis of 43 studies showed that the pooled prevalence of bladder bowel dysfunction is as high as 40%. And with bladder bowel dysfunction, there is an increased risk of recurrent UTIs. Bladder bowel dysfunction is an independent predictor of a UTI, delays the resolution of VUR, and treating bladder bowel dysfunction also results in downgrading of VUR. So the guideline that the Indian Society of Pediatric Nephrology published in 2023 suggested that all children with UTI should be evaluated for bladder bowel dysfunction, and using a formal scoring system such as the dysfunctional voiding scoring system. And prophylaxis should be given to patients who have recurrent febrile UTI and bladder bowel dysfunction, irrespective of the presence of VUR. Now, we know that VUR is associated with the renal scarring, but there are two kinds of renal scarrings that happen in these patients. We know that UTI can result in inflammation in the renal parenchyma and can result in scars. However, we also know that there are several children with VUR who are detected antenatally, who have not had a UTI, will also have damaged kidneys. And the same is true for asymptomatic siblings of VUR, who can also be found to have renal damage. And therefore, we now understand that there is some kind of a congenital scarring, or what you can call it as hypodysplasia or maldevelopment of the kidney, which results in damage in patients with VUR. And this is generally the more important one because it results in global damage, predisposes to hypertension and renal failure, more often seen in boys and with dilated VUR. And clearly this we cannot change with any kind of therapy because it is a maldeveloped kidney. On the other hand, post-infection scarring, the occurrence rate would be about 10 to 15% from the randomized controlled trials that have happened where patients were in the placebo limb or no treatment arm. And these scars are generally small, and they have little risk of hypertension and kidney failure, and they're more often seen in girls, and these may be prevented by interventions. However, as Jitendra was telling you, that when you look at antibiotic prophylaxis, the risk of scarring remains unchanged even in those patients where the UTIs are also prevented. So as I said, primary VUR resolves even the higher grades, including grade 4 and 5 also. And you could see that almost in this cohort of 230 children who were followed up for 15 years, 73% of them had either no VUR or grade 1 reflux at 10 years. So when you wait for these patients and gradually with passage of time as they grow, their VUR resolves. Similarly, this is the other cohort, which is a very large cohort from Brazil, 735 children, and they found that the median resolution time of reflux was much shorter for the lower grades of reflux, grade 1 and 2, roughly about 3 years, as opposed to grade 3, which was 98 months, and 4 and 5, which was even longer, generally about 12 and 13 years. So we looked at the outcomes of children with primary VUR in a prospective manner. These also included, the whole cohort included patients who were a part of the randomized controlled trial that we carried out looking at antibiotic prophylaxis versus placebo. And subsequently also from 2014 onwards, the patients were kept in follow-up as a prospective registry. The difference is that our patients are predominantly boys as opposed to the US cohorts, which are predominantly girls. And the mean age at diagnosis is longer here. We generally pick them up at around 4 years, 3 to 4 years of age, as opposed to in the West, where they would pick them up very early in first year of life itself. Majority of the VUR is picked up after a UTI. A small proportion of also diagnosed after antenatal hydronephrosis. And a significant proportion of VUR may also be diagnosed incidentally when a child is being investigated for hypertension or a presence of an underlying chronic kidney disease. The ultrasonic abnormalities typically show 60% of patients in our cohort had hypoplasia and some other congenital anomalies of urinary tract, such as multicystic dysplastic kidney, ductal ileal system, horseshoe kidney. Almost half of the patients had bilateral VUR. Bladder bowel dysfunction was present in almost 13%, but this was a lower figure as compared because we did not formally assess in almost 30% of the patients. CKD stage 3 to 5 was seen in almost 30%. So a lot of children were diagnosed with an underlying chronic kidney disease. And renal scarring was very prevalent. So that means most of these patients had a very severe phenotype, higher grades of reflux and more kidney scarring. Almost 3/4 of the patients had a renal scarring. We found that the recurrence of UTI was seen in 20% of patients, and the risk factors were younger age, female sex, UTI at presentation, and dilating VUR. And the median time to resolution in 173 children who had a follow-up scan done showed that in the non-dilating, which is grade 1 and 2 VUR, it was 37 months, as opposed to grade 3, 4, and 5, it was 84 months. It was a little less than the figures from the previous cohorts. The factors that affected resolution was the presence of renal scarring and grade of reflux. So higher the grade of reflux or renal scarring, the longer the reflux would take to resolve. When we look at the long-term outcomes, there is a question in mind that if it's a girl child and has a VUR, will it be associated with complications during pregnancy? And the data on this, the complications during pregnancy in a patient with VUR is very, very variable. Almost one of the studies showed that there are 12% complications in 282 pregnancies. When you look at the complications in general population, may not be more than 5 to 7%. There was a higher incidence of UTI during pregnancy, higher with the grade of VUR and also highest with the grade of scarring. Interestingly, it was not modified by surgery. Eclampsia was also higher when there was a bilateral renal scarring as opposed to no scarring or a unilateral scarring. And one of the studies from UK found that there was no difference in preeclampsia, low birth weight, and prematurity rates in patients whether they had VUR or they did not have a VUR. So it appears that the presence of scarring rather than reflux determines the morbidity during pregnancy. How about the risk of hypertension in primary VUR? Again, it is very variable, and it all depends on the phenotype of patients that you study. So it's been reported from 5 to 27%, but if you have predominantly in your cohort patients who have bilateral renal scarring, high-grade reflux, then the likelihood of having hypertension is also higher, as opposed to if you have only VUR, which is not associated with the scarring, then the rates of hypertension would be lower. So the retrospective study from the Brazilian cohort of 735 patients, which had a mix of all these patients, showed 3% developed hypertension. But the probability of hypertension, again, is important because it will depend on the age of the child. So generally, when the child is adolescent, then the likelihood of picking up hypertension is higher. So as the age increases, the probability of hypertension increases from 2% at 10 years to 15% at 21 years. And it's much higher in those who have bilateral renal damage as opposed to unilateral renal damage. So we had this question because we understand that scars that are formed by following a UTI or which is post-UTI scarring are small in number and have also been shown that there is little risk of hypertension and CKD in these patients. So we tried to find out whether small scars in a high-grade VUR, do they have any significance or not? So we looked at 40 children with high-grade reflux, 3, 4, and 5, and divided them into two with the ones with no scar versus grade 2 scar, which means 3 to 4 renal segments showing a scar, and who also had normal renal function. So we had a in this small study, we had 20 patients each with mild scarring and no scarring. When you look at the EGFR renal function reserve, this we did after giving a protein load. We looked at the urine concentrating ability and the beta-2 microglobulin levels. They were no different in the two groups. However, when we looked at the ambulatory blood pressure monitoring in these patients who had small scars also, they did have a higher rate of ambulatory hypertension. So it appears that even if patient has a small scar or mild scarring, they should be screened regularly for occurrence of hypertension. How about the risk of end-stage kidney disease? The rate of reflux-associated nephropathy is about 5% in various registries. And if you look at again the Brazilian cohort, which showed that the probability of CKD and end-stage kidney failure at 10 years was 15% and 5% of end-stage kidney disease. And a very important fact is that if there is normal DMSS scan at diagnosis, then there is very little risk of CKD, and most of these children will not develop chronic kidney disease. Overall, since the prevalence of VUR is very high, you look at the reflux attribute, the ESKD that is attributed to reflux, it's a very, very small proportion. So overall, attributing CKD or end-stage kidney disease to VUR is not a very a logical way, because most of the reflux that develop end-stage kidney disease, they have congenital hypodysplasia or renal scarring. If you look at what has happened to the renal scarring and end-stage kidney disease over a period of time, we have been treating these patients with surgery and antibiotic prophylaxis. And this is the data from the Australian New Zealand registry from 71 to 98. You can see that there is no difference. The prevalence of reflux associated end-stage kidney disease has remained constant. And the same is true from the North American Pediatric Transplant Registry data. You can look at the reflux nephropathy, it has not changed. So whatever we have been doing to the VUR has not resulted in any significant decline in the end-stage kidney disease attributable to reflux. And the reason here seems that since the ESKD is happening because of the congenital dysplasia, and therefore something that cannot be modified, and that is why there's been no difference or no decline in ESKD seen over a period of time. And this is how the therapy of primary VUR has changed from 1980s to now. You can see that predominantly it was surgical in the early years, and then it shifted to low-dose antibiotic prophylaxis. And in last 3-4 years, a lot of guidelines are also talking about surveillance alone and not giving even antibiotic prophylaxis to some children. And these are some of the key trials that have shaped the guidelines. And Jitendra did mention about the RIVER, the PREVENT trial, and the PREDICT trial. And there is a role for the ureteric implantation and endoscopic treatment, which has been there all this while along the medical treatment as well. So this is the guideline that we published, which is an evidence-based clinical practice guideline for the management of VUR. And there, for treatment of VUR, the ISPN panel, guideline panel suggested prophylaxis should be the first line for managing high-grade VUR, and prophylaxis is not indicated in the low-grade VUR. And we suggested that surgical reimplantation may be considered in high-grade VUR with recurrent breakthrough UTIs in a patient who is on prophylaxis. In terms of whether surgical intervention, there are clinical practice points of the one where the evidence is not very robust, but these are more like suggestion. So the guidelines mention that in high-grade VUR, surgical intervention may be an alternative for parental hesitancy to use antibiotics. So sometimes you find patients in your clinical practice who are resistant or who are not very keen on taking antibiotic prophylaxis for a long period, and they would opt for surgical intervention. And also that option of endoscopic treatment versus reimplantation should be discussed with parents when surgical intervention is required. So we need to discuss this because endoscopic treatment is less invasive as opposed to reimplantation, although it has a higher failure rate. So over the time, we have seen that in VUR, interventions have not impacted renal damage and end-stage kidney failure. Surgery, as such, is similar to antibiotic prophylaxis. It doesn't even help. It doesn't help in retarding progression to end-stage kidney disease. And we understand that dysplasia and not the reflux causes end-stage kidney disease. And it seems like dysplasia, VUR, and UTI, they are all present in a given patient, but then one is not causing the other. And over the period of time, we have seen that correcting reflux and preventing UTI hasn't changed the final outcome, which is end-stage kidney failure. So these are the guidelines on how to follow up a patient of VUR in terms of monitoring the long-term complications. We suggested that VUR needs periodic follow-up until the VUR is considered clinically insignificant, and monitoring for the renal growth in high-grade reflux and those with starved kidney should be done using ultrasound. DMS is not necessary to be repeated because it has radiation and should only be done in those who develop a recurrent febrile UTI. Patients who already have scarred kidneys or reflux nephropathy need long-term follow-up. They do not require, again, repeat MCUs and only should be done if you're planning a surgical intervention. Again, to find out whether the reflux has resolved, DRCG is not routinely required, but it may be considered for resolution of reflux if the family insists. And generally, it again should be done for a high-grade reflux, not before the child is 7 or 8 years of age. Children who have reflux nephropathy should undergo regular ambulatory blood pressure monitoring, eGFR estimation, and proteinuria measurement, because these are the complications that patients who have scarred kidneys can have. Those who have already developed CKD should be managed according to standard guidelines. And children who have reflux nephropathy, when they turn 18 or 20, they should undergo a transition of care to adult nephrology. So to summarize, majority of VUR, including severe grades, resolve. Congenital scarring is the one that determines the risk of end-stage kidney disease and hypertension and proteinuria. Pregnancy-related complications are variable, and most of them are associated with severe forms of scarring. Post-urinary tract infection scarring is associated with little risk of hypertension and CKD. And we understand that now that dysplasia with VUR is the one that causes end-stage kidney disease and not the scars which occur after a UTI. Thank you very much for your patient listening. Sir.
I enjoyed very much your talk. Your population is very unique because you have 2/3 of patients are males, so I think most of patients you're seeing is with congenital dysplasia, because also I see very high incidence of renal scarring. So is it that because this is such a specialty hospital that you're missing the females who have, recurrent urinary tract infection? They don't come here, they go out to different places. Is that because, or what I'm trying to say, you're seeing the severe cases, the ones with the dysplasia? It's very, very unique population compared to other populations.
Yeah, absolutely. I agree with you, because we are a tertiary care hospital and a lot of these patients come from pediatric surgery also, and the ones that are really more severe forms, and that's why we are seeing the more severe phenotypes. Also, one of the reasons could be that the primary physicians are seeing the girls that with UTI first, and maybe they are not even referring those patients to us. The ones who have scarred kidneys are selectively referred. So the data is biased in terms of the population in our cohort.
Another question I wanted to ask you, maybe I missed it in your study, that you didn't mention the incidence of hypertension in that group of males. That what was the incidence of hypertension? Because these are older kids. So
in our cohort,
yeah,
we are still analyzing. There's a study which we are conducting in all adolescents beyond 10 years of age. We are looking at ABPM in all those patients, and we have more than 100 odd patients to find out what is the true prevalence of hypertension in our cohort of patients. So that data I didn't show.
yeah. No, very, very interesting study. Thank you.
Thank you.
Is reflux nephropathy still a well-known or important cause of hypertension in adults? We were told that even one large scar in a kidney can cause severe hypertension. This is a long time out.
So that long-term data is there from the Wennerstorm, the study from the Gothenburg cohort, where they followed up patients who had UTI and small scars. They followed them up for almost 20 years, and they found that the risk of hypertension was low. So that's why they concluded that the post-UTI renal scars, they do not result in hypertension. They are not a significant cause of hypertension in adults. On the other hand, if you have a VUR with a scarred kidney, the chances of having hypertension is much higher.
You see, when the Prof. Bailey coined the term reflux neuropathy, it was before the days of the MSA. and we would diagnose a scar on the basis of IVP, or depression, and the ballooning of what the calluses, this kind of thing. And these were patients, they must have been patients having severe VUR over a period of time.
So that-
And actually, there were even reports of doing a localized or heminephrectomy to cure hypertension. These are all studies, of course.
Yes, sir. I think they were picking up really large scars when the days of IVP. Now we pick up even smaller scars with DMSA scan, and that's. Sir.
I think we have a lot of trainees here, and I think we should clarify as to when do you call a scar a scar? Because when the DMSA came into existence and when we started using it, we realized that some of these patches which were considered as scars were not really scars, because at the end of 6 months, if you repeated a DMSA, they had disappeared. So that is something which I think should be clarified, especially keeping in view that we have trainees here.
Yes, sir. So I would, for the sake of residents, when you do a DMSA scan early in the episode of a UTI, then you pick up inflammatory abnormalities, and these are transient. And the ISPN guideline now clearly mentions that you should not do a DMSA scan, the early DMSA scan, whether to predict a VUR or not. You should not be doing it because it will show you a transient abnormality. It will result in a lot of anxiety among the parents. And these are the scars that disappear after 6 months. So we generally recommend scans to be done after 4 to 6 months, where they will pick up a permanent renal damage, which is more relevant in the long-term follow-up of this patient.
Very true. But what you're talking about is acute pyelonephritis, whereas the scar is there. Because acute pyelonephritis, you will see the similar changes in DMSA, but it disappears.
So the other thing that we've realized in some of our patients is that in the infancy, sometimes the DMSA scan also doesn't pick up a very small abnormality. And this is interesting because the recent PREDICT trial, which looked at infants who were diagnosed to have VUR after being diagnosed as antenatal hydronephrosis, and these patients never had a UTI, and they gave antibiotic prophylaxis. Jitendra talked about it, and the other group placebo. And in that group of patients, they found that 18% of patients who did not have a UTI also had appearance of DMSA abnormalities, which means something that the authors could not explain. But to me, it appears that perhaps these were abnormalities which are present, which have not been picked up on the DMSA scan, and that's how they show up when the child grows. And I've had 1 or 2 such patients whose DMSA scan in the first 2 years of life was absolutely normal. And they did show up with some scars later on at 8 years or 9 years when a DMSA was done for some reason. And the family was very disturbed that the previous DMSA scan was absolutely normal, and why is this happened? So we really don't know what is that, but then maybe something that's not picked up very early in life.
Right. So a good corollary to what is being discussed just now. So if you have an acute pyelonephritis, a fair number of these may go to a full scar formation. A majority might reverse also. It's a photopenic area to begin with. It is only when you resume normal growth around that the photopenic area, which is negative, will start appearing, because the growth around it will show, and then the negative will then become apparent. So this was something which was very appalling when I read in detail the IRS study paper, Gene Smelly, 5-year study and 10-year study, and I realized that the scars continued to be formed in the medical group at the end of 10-year study, where they had all stopped after surgical intervention, which was because once you have done it, then you allow the growth to resume, and the scars appeared. So even after surgery, scars appeared, because the reason was Dr. Pankaj has mentioned, they appear later on because the growth has resumed now. But in the medical group, which was continued on prophylaxis, scars continued to appear throughout the period of the study. It stopped at 10 years. So obviously, we don't know what happened after that. So I think there's a lot to do with the technical aspects and how we pick up in DMSA. Right? Thank you.
Thank you.
Thank you, sir. Moving ahead with the session, it is my proud privilege to invite Dr. Meenu Bajpai, ex-HOD of Pediatric Surgery, for his talk on intention to treat versus intention to cure in primary VUR.
She's putting the slides together. Thank you very much. And it is such a privilege to be here in the same audience and be part of the audience with which we have grown. And seeing our teachers, Professor Mitra, Professor Puri, Professor Shivastav, Dr. Bagga, our colleague, everyone around. And we have learned so much. I remember the committee room, the director's board room, which is now Dr. Srinivas's committee room. That's the only boardroom we had once upon a time. And there, the early ISPN meetings were held. I remember sitting next to Dr. Bagga and talking to him. And that made me realize that as surgeons, we should share our experiences, frankly, as to what and we learned from the pediatric presentation, the medical part of it. And we also realized that became very conscious that we should have evidence-based whatever we are doing, which led me to do some pilot studies, which again, which I'm going to share with you today. A very good morning to all of you once again. I've learned a lot from Dr. Pankaj also because his talks are preceded by my talk in many meetings. And so, well, I'll just stick to some of the things which I have learned and the study which I have conducted and the literature which is now available, which supports something or the other. I've called it primary VUR, intention to treat or intention to cure reflux, is because we stop reflux. I mean, our business is to stop reflux as surgeons. And therefore, what happens, what goes into account when we proceed in that direction and what happens after that, what changes does it make in the biology of the system when we stop reflux. So, as we all know and we discussed just now, in reflux, normally ureter should put urine into the bladder, which should come out during micturition. But here, there is a ureter-vesical junction defect, which was first reported by Hodgson and Edwards way back in 1950s. And they said that if urine goes back, then between the cycles of micturition, it sits in the bladder, invites infection and mixes with more urine. This cycle continues, which is the cause of infection. And this infection then has a risk of causing, not every infection would cause pyelonephritis, but every episode of infection has a certain risk of pyelonephritis. Every episode of pyelonephritis is a risk of leaving behind a scar with decreased function, end-stage renal disease, hypertension, and reduced somatic growth. In girls in childbearing age, a scar would carry high risk of eclampsia, repeated abortions, small for dead babies. So as Professor Shivastav and Dr. Puri mentioned about the scars, and Pankaj alluded to it, scars are very notorious. They carry on their ominous sort of consequences later on also. Here, Dr. Puri, step aside from the lecture and a question Dr. Puri has asked about why boys more. In most of our studies published from our country, boys' preponderance is not because of the disease propensity alone, but also because the families bring boys more, unfortunately. So therefore, if you look at any prevalence or incidence, we find suddenly boys are more. I have been asked this question by the reviewers from international journals, the same thing, and that was the only answer I could give. And obviously the papers were accepted. So the goals of treatment is to prevent renal injury, symptomatic pyelonephritis, other complications which we have talked about. We have certain modalities like medical treatment, which is largely prophylaxis, endoscopic injection, which is now on the middle of the road, surgery, whether laparoscopy, open surgery, or robotics. Now, this study had seized our attention. I think most of the nephrologists across the world who had anything to do with VOR were indoctrinated hugely by this Jean Smelly's paper, which was a 10-year study. First arm was 5 years of European component, and the second 5 years were of American data. So if you look at it, very clear. At the end of 10 years, half the patients stop refluxing. I see it, half the patients still reflux. And my question also was that if half the patients after 10 years have stopped refluxing, it took 10 years, and those 10 years, were they sacrosanct? Were they safe for the kidneys? Did they leave behind damage which will be manifested later on? So even if it was looking positive that after 10 years, 50% will subside, if you take it from that angle, you may see a very bright light. But then you see children grow who have another 70 or 90 years to live. We are worried about this sterile reflux. So 50% refluxing even at 10 years, is sterile reflux safe for kidneys? Are antibiotics safe? This was many years ago. Now RIVUR trial, and many of us are realizing that antibiotic prophylaxis per se has its own side effects. So, pyelonephritis, we now have realized. I'll take a pause and welcome Professor Meherban Singh, sir. Welcome, sir. Professor Meherban Singh, our former neonatologist. So we have Dr. Chaudhary, Dr. Menon, Dr. N.K. Rola, all of us are here. I'll just continue with antibiotics and reflux. So what is being realized now, and the literature is agog, that pyelonephritis occurs despite antibiotics. Now this is period. It is now realized. Continuing antibiotics has its own side effect in terms of resistance and even otitis media, etc. Nice guidance. National Institute of Clinical Epidemiology in the UK keeps on sending guidance periodically. The bottom line here is prophylactic antibiotics do not reduce scarring in children less than 30 months of age who have grade 2 to 4 reflux. And therefore, they recommended that you stop giving prophylaxis. Treat UTI when it comes with that. Now, very young babies don't come with UTIs. They come with vague symptoms, not being well, etc. And they go to the first filter, that is the GPs, and they would treat them for respiratory infection, viral or whatever. So therefore, missing out that important period of 30 months after birth without any prophylaxis, which is now proved to be better than surveillance, is a very big risk. These kidneys, which are very vulnerable, would develop infection, pyelonephritis, and all the cascade of events. So therefore, NICE guidance very clearly underscored that there is a flaw in our approach. The randomized intervention VUR trial, which Dr. Pankaj very elegantly alluded to, they also have come to the conclusion in the first 2 years of their study data, 2014, antibiotics are better than placebo if given for short periods, but they have side effects if prolonged with prolonged use. So infants have as I mentioned, I've underscored it again, infants have non-specific symptoms of UTI. And in an ICU, 50% of the newborns with UTI have underlying VUR as the cause. 1/3 of children admitted in pediatric ward with UTI have VUR as an underlying cause. This is a huge amount of contribution of VUR to UTIs and its consequences. Now, the Cochrane review of 2011 mentioned that 40% children would develop scar despite antibiotics on medical treatment. Surgical treatment after surgery, post-op resolution rate after 4 to 5 years is 93 to 99%. The lesser rates are for higher grades. Surgery reduces the incidence of pyelonephritis. Now, coming back to the original query, is sterile reflux safe? So Hohenfeller and many other people had come out with data on the tubulointerstitial compartment where all fibrosis takes place. We looked at actually what is causing scar. And therefore, with the paradigm shift of better understanding of the biology of renal injury, questions being asked about antibiotic usage, and the availability, thanks to Dr. Puri, of endoscopic injection, which silenced many critics of surgery, because surgery, every thing has got a price. Surgery had a price. Infection, some complication. Endoscopic injection when it came, kind of a panacea for giving treatment in a very short period of time with great success and least complications, if none. So looking at why scar forms, and kids come to us with normal kidneys, we put them on medicines and they develop scars later on. Something must be happening right from day 0 or 1, which we are missing out. So I looked at the process of scar formation. If you trace the steps back, you find that the primary player of the damage to the kidney, which is apoptosis or fibrosis, starts very early on during the neonatal period when there is a reflux or any other pathology related to tubulointerstitial compartment. So plasma renin activity was raised. We did some studies as a post hoc analysis. We were not biased. We kept the data as a post hoc analysis and then continued. And when we went back, we realized that renin was raised right from the beginning. And we were just sitting for the right indications to treat reflux. So now if you look at the glomerular apparatus, this is juxtaglomerular apparatus high up there. And in VUR, there is a water hammer effect. Every time there is a reflux, urine would go back as a water hammer, create hemodynamic turbulations in the juxtaglomerular apparatus area and lead to renin release. The more there is a renin, the substrate is there and it leads to more production of angiotensin II. I'm not going to the details of biology. I'm just touching these points. There are residents who can go look into the literature, which we have published from the department. So in this study, again, the first study was of 26 cases where we had done open reimplantation way back in the early 90s. And when we found with a post hoc analysis, all these patients after reimplantation, the plasma renin activity which was raised had come down. So post hoc analysis revealed renin was high right from the beginning. We intervened when the scars had formed, but when after reimplantation of ureters and the reflux was stopped, we found the renin had come down. So which led us to believe that these are early markers. And this marker would eventually, if ignored, lead to injury in the form of scarring. And therefore, if we wait for scar to appear, we have caused irreparable, irreversible injury. So therefore, we should become more alert and sit up when the reflux is there and renin is high. We should rather go for intervention at that point of time. This philosophy we continued in the variety of CACUT, congenital abnormalities of the kidney and urinary tract, and I'm very happy that consistently we were able to show that this was high. To the extent that this is the time to talk about the dysplasia. So there is an often repeat discussion that newborns who have got hydronephrosis proved to be reflux, they already had focal dysplasia. What is dysplasia? And I think Dr. Puri mentioned to this. What is dysplasia? We have shown that in utero as well, the renin is high in children who have reflux or any form of CACUT. In fact, Bhadu, one of our residents, did a thesis on that. He did chordosynthesis and he showed that these patients had high levels of renin activity even in utero. So if there is a reflux in utero which is known and there is a raised RAS system is disturbed, the injury may be happening, and that is what dysplasia is all about. Another obstetrician in Greece, he's an obstetrician and he reported 11 cases with hydronephrosis in which he had done a chordosynthesis, and he showed that all the patients he had actually quoted my paper published in Journal of Urology in 2007. 3 years later, he came out with the data that what we had said was really right, and in utero, renin is high. So I think for a brief period of time, till we have huge amount of data, it will spiral more research to show that reflux continues in utero also. It raises RAS system activation and it may be the cause of what is happening. So we should be rather alarmed on that. We published this extensively. We even added, when the function was not improving in terms of GFR, we added ACE inhibitors and we found the GFR started improving. So as Prabhu was talking about inflammatory sort of molecules, so something is happening all the time, and we can extend the 4th phase of treatment after reimplantation or endoscopic treatment to add ACE inhibitors, which will also improve renal function. Now, coming back to continuing on endoscopic injection, a meta-analysis done almost 20 years ago by Jack Elder, who has been very profoundly active in this, along with Professor Puri. 63 articles were reviewed, more than 5,000 patients, 8,000 renal units, 7 prospective studies, 3 randomized and prospective. He came to the conclusion about the virtues of endoscopic injection. At this juncture, I have not quoted here, but Caleb Nelson, whom I was with as a Fulbright in Hopkins, and Pau Kayon from Europe, they had done the study. They give 3 options to the families: open surgery, antibiotic prophylaxis, or endoscopic injection. Similarly, Caleb Nelson also did a survey of families, and most of them said we'll go for endoscopic injection rather than procrastinated therapy of antibiotic prophylaxis. Anyway, I've mentioned this because I'm quoting literatures now. in our institute, and this was published so many years ago, 99 consecutive ureters refluxing. We gave Deflux, which was just available at that time, soon after Dr. Puri's visit. And we found that except for the very high-grade reflux, which required second or third injection, this was a very effective way to treat. And even after 2 or 3 injections in high grade, we were able to achieve 94% success rate. So these are the reports which I have mentioned. Earlier we used to chase them by an MCU to see whether the deflux is happening or not, has it stopped or not. Now we don't do MCUs after deflux injection because it is such a straightforward procedure, and there are defluxinomas that we follow and see by ultrasound. Everything is quiet. So these are the MCUs of those time, which shows that in follow-up there is no reflux after deflux. Now, is it as viable an alternatives as to open surgery in terms of curing reflux? And so we did molecular observation. We found that plasma renin activity comes down after deflux as it was coming down after open surgery. The microalbuminuria, which was high in refluxing patient, came down also, just like we got it in open surgery. So it is as effective a technique. We published this on several occasions in Journal of Pediatric Urology, Journal of Urology, Kidney International, etc. So why surgery is intention to cure? So coming again to the literature, years ago, I talked about Hodgson, who first realized in paraplegic patient that the UV junction is conked off. Historically, as early as Galen, who looked like to be such an old experiments. Leonardo da Vinci, I'm naming people whom we know somehow in terms of literature, their paintings or whatever. And he has postulated that the UV junction in the bodies he dissected was abnormal. And he even mentioned some techniques that it should be treated. And John Sampson actually did some dissections of the uretrovesical junction to find the tunnel. So this has been there at the back of the mind, and people went forward with this philosophy. Barry O'Donnell in 2003, again from the same place as Professor Puri, he got his American Academy of Pediatric medal in 2003. And I'm telling you, in short, he made 5 points. He said, VUR is rare, but it is progressive. Grading is not important. And he said that VUR always causes progressive renal disease. So these are stalwarts, people who were actually father figures, who actually brought pediatric urology to the world as a specialty. Innes William, Barry O'Donnell, Professor Puri, all these people have studied this and made very astute observations. Now, a recent 2024 literature from Nature Review, of which Professor Puri is also one of the primary authors, found there's an association of VUR, UTI, renal injury, which is well established. The main goal is to prevention of recurrent UTIs, minimize the risk of renal scarring, and long-term renal impairment. So all this literature, gone era, concurrent, and futuristic projections are also pointing towards these things. So the key messages, which I would rather share what I have understood about reflux. Science is not truth. It is a search for truth. It will continue. The caravan will continue. People will come and we'll add so many things. Prabodh was quoting such beautiful literature. We did studies on penetrance studies. As a birth defect surgeon, families used to ask these questions, which Prabodh put forth, that is my next child going to have a problem? Is his or her child is going to have a problem? We did penetrance study. Santosh Day is here. If he has not left already, we did a study. Would you stand up and let people recognize you? Somebody will chase you to guide me. We did studies to see the IVF babies who could be followed up, and we found that how children who have these anomalies get aborted. So there are issues which are yet unsolved. They will continue, and I'm sure. So with this, antibiotics better than placebo for short periods, but side effect with prolonged use. Continuing VUR has the potential to cause long-term renal injury. Renin-angiotensin system has been shown to be activated. Sterile reflux is harmful. VUR may resolve in half the cases first 2 years. AUA is very strong about it. Don't do reimplantations before 2 years, before 18 months of age, because they say that uretrovesical junction is still developing. So if you do an intervention, you are likely to leave behind dysfunction of the bladder for a very, very long time. That's where endoscopic injection come to the fore. You can do that. You don't have to do surgery if it comes to that. Based upon that, we have made an algorithm, which we'll discuss later. But I'm just wrapping it up here. So ureteric implantation, as I said, it should be avoided before 18 months. We still have a reflux to offer. So take into account how do we manage a child who comes to us. Individual factors, which are risk factors for age, sex, grade of reflux, bilaterality, bladder dysfunction, and bowel function. Antibiotics have some role for short periods. Endoscopic injection and surgery are offered with the intention to cure, to stop reflux, and more effective in long-term renal outcomes. And parental preferences should be offered. You should give them the three options. And I told you about Paul Guyon's study as well as that of Caleb Nelson. People have chosen reflux over all other modalities. So with this, I would not go for algorithm because it is hidden within it. In case we discuss it, we'll come to that. How should we approach a fresh case with VUR who's below 2 years and after 2 years? What factors do we take into consideration? That's what I have talked about, but I know that I have crossed the limits of my time. I won't continue, but I can discuss it anytime. Thank you so much.
Thank you, sir, for sharing your valuable thoughts on the topic. Now, I would like to invite Dr. Ranjan Dua, sir, for sharing his presentation on decision for surgical intervention.
Thank you, Sugandha. Respected Director Sir, dignitaries. So my role is to take you through the decisions that we take while conducting surgery or offering surgery to these patients. First question is whether to offer it or not, and then multiple decisions based on this. So before we embark on this journey for offering surgery, the background which already has been covered by Dr. Pankaj, Dr. Prabodh, we have to know the natural history of it, as and rightly put forward by Bajpai sir also, that to the tune of about 80% of the low grade ones till grade 3 would naturally they would subside by 2 years or 3 years before they develop toilet training, and also in higher grades also they would disappear to the tune of 20%. However, as surgeons, we have to catch those which would not probably resolve. Those are the cases which have duple ureter or an UV junction abnormality with improper backing, probably ureterocele or a Hutch diverticular setting there. So these are the cases where probably we have to decrease the threshold of conservative management. We might have to do something early. So that we have to be aware of, and that is the reason we have to do MCUG rather than doing DRCG. MCUG being which would show us the anatomical details much better than the DRCG. This is the first baseline MCUG that we do. Subsequently, we have to also understand whether we are dealing with primary VUR or it's a secondary VUR, and depending on that, many questions would be answered. As in the given images, you can see these are cases of posterior urethral valve and another with an anterior urethral valve. We can also have a stricture. It could be any obstruction distally, which could be the cause of this reflux, or a neurogenic bladder secondary or teether cord syndrome. So where you can deal the bladder, deal the pressures, deal the bladder with medical management, and automatically the VUR settles. And so is the case with the secondary causes, which have secondary to anatomical causes like the valve and anterior urethral valve. So I'll take you, this is the slide which will take you through the various interfaces where we need to decide something or the other for offering surgery. First question and foremost is why? Why after all we have to operate? This has partly been already answered actually by Dr. Pankaj, Dr. Bajpai, because surgery reduces pyelonephritis occurrence. But mind you, the last sentence which has been coming up now and has been proven by various studies that surgery, even after doing surgery, it probably is not enough. It's not causing anything to the progression to develop scarring later on. Probably what we are able to achieve is decreased number of febrile UTIs, and that is what also helps the patient during the course of the disease. So, but yes, the premise is that it decreases UTI and decreases the renal scarring. That was the original school of thought. and several guidelines have already been covered. But what crystallizes out of all this is that the current indication would stand something like that. It may have the last two, the persistent VUR in girls after puberty and parental preference for definitive solution are the relative indications, I would say, going through the presentations of Dr. Pankaj as well as Dr. Bajpai. But the first four are definite indications of surgery, where either it is a persistent or a high-grade VUR beyond the initial 2 to 3 years, and breakthrough febrile UTIs. And of course, failed endoscopic deflux, which again could be multiple actually. It is not a single shot deflux, and if it fails directly, we should not jump into it. We can offer a repeat injection and then of course decide whether surgery would help at this point or not. Going to the next question is, when exactly to offer? So sir rightly said it is not ideal to offer surgery before 1 year infancy, in fact 2 years. We would like to wait till the anatomy settles, the ureteric vesicle junction remodels, and then more so because handling this bladder is technically challenging before infancy. In neonate also, sometimes we might have to intervene if it is an extreme situation with pyonephrosis or urosepsis. In such a situation, it is better to do minimal in form of probably a PCN which can tide over the situation, or in extreme situation we can also do ureterostomy to get a window period and do definitive therapy in form of whatever is available, but decide it later on. Surgery should be the last option. And then of course there's the when UTI should not be there whenever we do reimplantation. That is a basic dictum in our surgical reconstructive surgery. What to operate? Here we do not have any controversy. There are only two options, Dexel versus Deflux or Dexel versus ureteric reimplantation. I'll not deal with the Deflux or Dexel because Professor Prem Puri would be who has pioneered it all along, would let us know about Deflux. But for ureteric reimplantation, which reimplantation as surgeons we should choose? Now it is pretty clear that high-grade reflux, if it is bilateral, Cohen's has stood the test of time, and most of the surgeons would choose cross-diagonal Cohen's, which is the standard surgical option we choose. For unilateral VUR, because minimally accessed surgery has been in vogue for some time, Lich-Grigor extravesical is the procedure of choice. And when long submucosal tunnel is needed, or if it is a redo surgery, a Ledbetter-Politano kind of a surgery is often chosen. So it depends on the bilaterality, it depends on the approach, access, open versus minimally access. If you have an access to robotic, it will decide, and your surgical own expertise will also be the factor which will help you decide which technique to use. The main principle being to get a tunnel length of approximately 4.5 to 5 in order to get that flap valve kind of mechanism. Now salient points, this is just for our residents who must know that the in Cohen's, the neoureteric orifice would be at a very awkward angle which will not be accessible for subsequent endourological procedures. One should keep that in mind. For Ledbetter-Politano, they have high chances of kinking and some obstruction, which we should always keep in mind when we follow up. Glenn Henderson and Lich-Grigor has its own problem of possible damage to the nerves. If we do it bilaterally, it will have post-operative retention and nerve damage related issues. And whenever we do a tapering uretroplasty for a mega ureter like a situation, it can have upper transient, although it can have upper tract dilatation. So we should not jump into doing a revision surgery immediately. We should expect this. Now, what's the flip side of ureteric reimplantation? So although we know that more than 95% success is expected, this is still an invasive procedure and has high morbidity, and close to 1 week of or 7 days of stay is expected. There are complications inherent, and there would be also a group of patients where we might have to offer redo surgery. So this has to be there in the background. And some other conditions, other surgical options that are also there. It's not ending at ureteral reimplantation, and they are ureterostomy and circumcision. I thought to touch upon because that's also important in VUR. This is not the definitive therapy, but we must know what to offer. That is where decision making comes. So whether to do unilateral ureterostomy or a bilateral ureterostomy or an upper or a lower ureterostomy or a loop ureterostomy kind of design, or a Sober's kind of a design, that will all depend on the clinical profile of the patient. Whether it is a unilateral VUR, what's the morphology of the ureter, is it tortuous, or even the split renal function of the kidneys. So for example, if a kidney is knocked off already, a very poorly functioning kidney, and having bilateral VUR, we might just do like to salvage the better functioning one and do a loop ureterostomy on the better one, and do Sober's kind of ureterostomy, which will ensure cycling of the bladder downstream, and then you can do definitive therapy later on. So these are things where we have to decide to choose between various options that are available. Last point is about circumcision. This has been in vogue, discussion about whether to offer circumcision or not. So recently a publication, a systematic review done on 8968 patients, which looked into the incidence of UTI in those patients who were antenatally diagnosed hydronephrosis. So in that they found, and out of that only 9 studies had included ANH because of VUR. So that is around 1400 patients. And what they found is that around 28% had overall incidence of UTI. And when we split them into those between circumcised and uncircumcised, 12 and 37. So that was a figure which, when pooled, showed that there's a significant protective effect on those who were circumcised. And sub-analysis showed that if we analyze the high grade ones as one group and the lower grade as another group, so the circumcision procedure itself had a protective effect on those who had high grade of reflux. So with that, I think the key takeaways are that already, just reiterating that not all VUR cases would require surgery. We have to properly select those which require, and definitely grade 4 and 5, which are having recurrent febrile UTIs and are developing this, again, progressive renal scarring, debatable, and a tailored patient-centric approach has to be based on the parental preference, surgical expertise available, as Dr. Bajpai sir had also mentioned. Thank you.
Thank you, sir, for enlightening us on the topic. I would now like to invite Dr. Vishesh Jain, sir, to enlighten us on the management of VOR in minimally access surgery.
A very good afternoon to all. It's a privilege to speak in front of my teachers who taught me surgery. Privilege to speak in front of visionaries who established specialties of nephrology, pediatric nephrology and neonatology in this country and propagated it. And above all, a privilege to speak in front of Professor Prem Puri. We are clinicians, if we realize we can only modify the management of few thousand children with VUR, but he single-handedly has modified the management of millions of children with VUR. So I start with my talk about minimal access surgery. Now, Dr. Anjan used the term invasive. So minimal invasive surgery is a term which is not often used right now, which is rightly so. So we are only changing the approach towards surgery. We are still invasive because we are trying to maintain the same surgical principles that we do in open surgery, but only our access to do that particular surgery is limited. And antibiotic prophylaxis has been in vogue for long, and also reflux, but recently there's a lot of advancement that is being done in surgical nature of surgical management of VUR. So we'll talk about that also. So once we have decided upon the surgical approach of this condition, the first thing we see whether the kidney has some function or not, and whether it's worth preserving or not. If the patient is symptomatic and the kidney is not working fine, it's better to remove it. And if the kidney has function, then definitely, as Dr. Bajpai said, we plan to cure the reflux. So this has already been highlighted that this detusser backing and the maintenance of tunnel is extremely important. So if the ureter has a good backing, as the intravesical pressure rises, it presses upon the ureter, closes it. And if this mechanism is not active, then the patient has reflux. So the role of surgeon is to create this mechanism back through various procedures that we'll go through probably in next few slides. So the first approach Dr. Anjan also mentioned was Lisch-Gregor, which is an extravesical approach. That is, we are remaining outside the bladder. And because we're remaining outside the bladder, so the minimal access approach for this is laparoscopy, in which we create pneumoperitoneum and operate. So if we see, we create a defect in the detrusor muscle near the area of VUJ junction, and then we close the detrusor defect over the ureter, therefore increasing the length of the intravesical ureter. So this is the patient, and now we are standing at the cranial at the patient looking at the bladder. So we can see the bladder in center, and we can see we're very close to the VUS right now. There are iliac vessels on the left side. Yes, if the pointer is, yes, this is the iliac vessels, and this is the area of the ureter. So we know the ureter is retroperitoneal, so we are dissecting the ureter right now. Once we are able to dissect the ureter, we encircle it. And because we need to dissect at the VUJ junction, we need to hitch the bladder so that we can reach till the VUJ. And as we know, the VUJ is distal to the VUS, so we have to create a tunnel which is distal to the VUS, and then we'll get the ureter from this area that is distal to the VUS and start our dissection. So this is the VUS that we have to preserve. This is challenging in males. In females, we are much more fortunate because there is no VUS. And we dissect till the VUJ junction. Now, Dr. Anjan mentioned that bilateral has more chances because the uterus also carries the nerve supply of the bladder. So if you do this surgery on both the sides, there's more chances of voiding dysfunction, which may be temporary in these patients. So now we're creating a detrusor defect in this patient. Now this is extreme magnification. That's the beauty of laparoscopy right now. We are operating with just 5 mm instruments right now, and look at the magnification we can get. Now this is the mucosa peeping out. We'll just extend the incision both superiorly and inferiorly, while attempting not to open the mucosa. Even if it's open, we'll just close it, but still it is wastage of few minutes. And detrusor has a good vascularity, so we have to use intermittent cautery to control for the bleeding. So this tunnel is being continued superiorly, and once we are done with that, we'll continue a bit inferiorly towards the vesicoureteral junction. Here we can see we are very close to the ureter right now, and we have to also undermine the edges. Now the importance of measuring, because we are operating in such great magnification, if we just go by visual cues, we'll always be creating a very small tunnel. So it's very important we use a scale, and that gauge piece had markings at every 1 centimeter so that we can realize and we can measure that how much tunnel we need to create. So we realize we need to create more tunnel. So again, that exercise continues. You again go more superior, and you divide and you extend the length of the tunnel. Now this is a good tunnel. Now we start suturing the area. Now the suturing, the angles are not good. That's why many people do it with robotic surgery, because with laparoscopy this is slightly difficult. So we take one bite of the detrusor from one edge. Then we pass the needle behind the ureter, coming on to the other edge. And we have to take multiple such bites with interpreted sutures. And with each suture, the ureter is being increasingly incorporated between the mucosa and the detrusor muscle. And this procedure is nearly a daycare procedure in many centers who do robotic surgery. So just to stress, the ease of surgery in these patients have increased over the past few years. And still, again, we felt that it's less. So you again released the bladder and again went up. So it's very important. When initially I started, I made smaller tunnels and this patient had reflux. So you have to measure and then create these tunnels. So once we do that, we close the bladder, we close the mucosa, the peritoneum over the ureter, and the procedure is done. There's no tendency to, the catheter is removed the next day, and the patient is discharged at day 2 at the most. Now, a psychoscopic approach, it's a very interesting approach because probably only pediatric surgeons do it. So we can call this a minimal invasive approach also, because we're not opening the bladder. So here we are really less invasive right now. So the surgical principles of the cohorns are still maintained. Now the ports are inserted directly into the bladder. One of the most difficult approach of this, difficult points of this approach is inserting the ports. So the procedure is same. We mobilize the ureter intravasically and we just pass them across the trigone, increasing the length of the ureter inside the bladder. So this is the patient, a 1 year, 10-month-old patient with bilateral high-grade VUR. So this, we inflate the bladder so that the bladder is apparent, and then we insert port directly into the bladder. So we have a 5 mm port, which is an optical port, and we have two 3 mm ports, which are our working ports. So initially the bladder is filled with water. We'll just suck this. And now again we are using, seeing the bladder from cranial to caudal, and this is the bladder neck through which both the ureter tubes are coming. And we are cannulating both the ureters. And after that we start the dissection. So the steps are essentially the same that we do in open surgery. Every step is same. We divide the mucosa, detrusor. We always start from the medial side because that is the place you will not harm the ureter much. And the magnification makes dissection very easy once you have idea. But the only issue is that you're operating under a very constrained space right now, and operating inside the bladder of a 2-year-old boy. And you have to ensure that you don't damage the supply of the bladder of the ureter. And in males also, again, the VUS is troublesome here because it sometimes appear on the inferior part of the defect. So once you have identified, mobilized the ureter effectively, you also mobilize on the other side, adequate length, and now you start creating a tunnel. As a person who was learning open surgery, I always felt this step was a bit blind, and Dr. Bhattagar also used various techniques like hydrodissection to do it perfectly. But in vesicoscopy, most of the times you can see the tunnel very nicely. You can see the fibers. I can dissect fiber by fiber going into the right plane. And now the tunnel is complete between both the meatus. And now, because we have mobilized the ureters, we have created a bigger hiatus. We'll just close this hiatus. This is a 4-0 suture we are using right now. And by closing the hiatus also, we push the uterus a bit more lateral and gain some extra length of the intravesical tunnel. We need to ensure that we're not very, very tight. And once we do this procedure, we again kind of pass the feed tube to ensure that we are not very tight. Now we have passed the left ureter to the right side. And this is the first anchoring suture in which we take detrusor also. And now we are passing the right ureter to the left side and fix that ureter. So the orifice the ureteric orifice is matured, and we close all the mucosal defects right now. We don't put dehiscents in these patients now, and we also remove the catheter after 2 days. And we have even stopped closing the 3 mm ports right now because they heal by themselves. So most of these patients do not have any catheter after 2 days, and we are able to discharge them after 3 days with a cure rate of roughly 95%. Some interesting scenarios we sometimes see in duplex kidneys where one moiety is not refluxing. Like in this patient, the reflux was only in the lower moiety and the upper moiety did not have reflux. So this is a unique opportunity for us to do something special like this. Patient, we first did the RGP. This is cystoscopy in which we can see that 2 orifice, one dilated orifice superior-laterally, and which we know belongs to the lower moiety which was refluxing, and this is the normal moiety. So we just cannulated this moiety, did a RGP to identify the anatomy. And now we are doing a laparoscopy. Now the patient is lateral. We are standing in front of the patient. That is the kidney here. And this is the colon that we are reflecting right now. So we know that 2 ureters. Our plan is that we will just anastomose the ureter which was refluxing to the ureter which was not refluxing. So here we can see the ureteric stent that we had inserted. These are the 2 ureters, one with the ureteric stent inside, and this is the ureter which was refluxing. So without going to the utrovesical junction, we'll just divide this ureter which was refluxing. And this procedure is usually very difficult if you do open, but the magnification again helps a lot during this surgery in laparoscopy. Now we dissect this ureter down to the bladder, ensuring we're not damaging the other ureter or hampering the supply of the other ureter, and we have to go beneath the fallopian tubes right now because she was a female. We spatulated the ureter of the lower moiety which was refluxing. Now we are opening the ureter, draining the upper moiety which was not refluxing. So we are depending on the mechanism
of the upper moiety, and we are replacing that uteric stent with a DJ stent because we want this anastomosis to be stented and drained, and we complete the anastomosis. This is the cosmetic outcome of a patient after vesicoscopic surgery. There are 3 mm instruments down below and the 5 mm port for that we had used for the optics. So there are limited studies which are comparing this with open approach. Definitely more time is needed, roughly 30 to 40 minutes more. However, it's been proven that we require less analgesia, lesser duration of bladder drainage, and lesser duration of hospital stay to the tune of 2 to 3 days lesser than the open surgery, and nearly equal success rates. Thank you. Sir? Sir, cost of surgery, actually sir, that's a very good question to answer. So most of our patients, so what happens once we always give an option of Dixel to the patient right now, but in a government setup, this is free to the patient. There's no cost to the patient. But otherwise, if you say Deflux to the patient, then Deflux is costly because the patient has to buy it. So in our scenario right now at department, many patients go for the surgery, and once you tell them that again the stay will be just 2 days and it will be free of cost, and the success rate is around 95%, 96%. Many of them opt for, and this is experience across VVSS also says the same thing, that many patients, given this all things, they opt for vesicoscopic surgery in their settings.
Talks with Niti Udyog, if you actually write them a letter asking them for permission for deflux, and they do give permission, even for patients in Ayushman. It's just a matter of doing the paperwork. You can't just admit a patient and then get it. Secondly, the laparoscopy charges is around 3,000. That's not much. Thirdly, in some of the hospitals that I've worked, initially just to encourage that we should not have any bias, like for instance in cesareans and normal deliveries, they've kept the charge same. I have actually in many hospitals suggested that lap and open should be charged same. You may increase one, decrease one, so that you are not biased by the surgical charges when you're doing. You can opt for one or the other. This makes it, I think it makes even as a surgeon or even as the patient think more logically. I mean, you should be adept at both to give the option. But if you can make the charges same, then that makes difference.
Mira, one point, just what you are saying. You see, even if it is 3 days, you are admitting the child for a few days, and forget about open surgery, endoscopic injection, a 5-minute job, and you can do 10 cases. No, we're just discussing it.
I'm just giving you how to go about it as the challenges that we are trying to overtake.
Yeah, Ayushman is a good thing to think about in case they can chip in.
Thank you, sir. We have this exceptional opportunity to hear from one of the most esteemed figures, world-renowned Professor Prem Puri. Professor Puri is the Newman Clinical Research Professor at University College Dublin and President of National Children's Research Centre at Ladies Children's Hospital. He's also President of World Federation of Associations of Pediatric Surgeons Foundation. His contributions to the field of pediatric surgical research have transformed the way we understand and treat congenital conditions, benefiting millions of children worldwide. Professor Puri's pioneering work, particularly in the management of vesicoureteral reflux, Hirschsprung's disease, and congenital diaphragmatic hernia, has reshaped clinical practices globally. With an illustrious career spanning decade, leadership roles in prestigious surgical associations, and extensive academic contributions, he stands as a true inspiration to the medical community. We are privileged to learn from his vast experience today. Please join me in extending a warm welcome to our distinguished speaker, Professor Prem Puri.
Okay. Okay. That's fine. Okay. This is the one, eh? Yes. Yeah. Well, good afternoon. First of all, I want to thank Professor Srinivas for inviting me. And what I'm going to do is I'm going to divide my talk into three parts. First, I'm going to mention briefly about research, because that's what I've done all my life. Why I should be doing research. And I tell you why I decided to talk about that part is I've been the editor-in-chief of Pediatric Surgery International for 21 years and on the editorial board of many other journals. And I've found in recent years, and I'm only talking on my own specialty, pediatric surgery, that not much worthwhile stuff is coming out of India. China, 20 years ago, their English was poor and the quality of their research work were not up to the mark. But in the last decade, Chinese are 10, 20 times ahead of India in pediatric surgical research. Their publications are more, their quality of work is more, and that's why I thought I'd briefly talk about that. And second part, I'll just, for the sake of the young people, I'll tell you briefly my own journey, how I was introduced to research. You always need a mentor, you need a godfather. Without that, you can't do it. And then I'll talk a little bit about the endoscopic treatment. Sorry, this. What? Yeah. So Ireland is a very small country. You know, when I went to Ireland 50 years ago, I wrote to my father, I said, Ireland is only little better than India. And now, currently, Ireland's GDP growth is the highest in EU. Average EU is 0.9, Ireland was 4.5. And it's all due to the politicians. They make or break their country. Because Ireland was doing not too well, but in late 90s and early 20s, they decided to borrow a lot of money, and all this money was spent in research and development in all fields, technology, medical, and that's where the fruits of. When I went there, the population was 3 million. In children's hospital that I was working, 325 beds. I was the only foreign medical graduate. You could walk around the area of Connaught Place, like in Ireland, Dublin, Grafton Street, O'Connell Street, and never see a foreigner. And now in the same hospital, 40% of the people working there are not born in Ireland. They brought in a lot of especially technological persons and professional, and now the population of Ireland is 5 million. 5 million is nothing, because Professor Srinivas was telling me that 5 million people actually attend the hospital outpatient every year here. So, and not only they put in a lot of money in development, but this is the university that I work, University College Dublin. In 2003, they set up a Conway Institute, and there are 100 Conway Fellows. These are all the professors or additional professors. For instance, I'm one of the Conway Fellow, and you are elected to be based on your research work. Not every person. So in this Conway Institute, which is a biomedical research institute, there are 450 experts, 100 Conway Fellows, 100 senior scientists, postdoctoral scientists, and 250 PhDs currently at the moment. And this is the new Children's Hospital in Dublin, which will open in the autumn of this year. This is the most costly building project that Ireland has ever taken, 2.2 billion euro for this hospital. And when I was talking of the politicians, how they spend money wisely in research and development, we have a health minister, but we also have a minister for children. That much importance they give to children in Ireland. We have a minister for education, but we also have a cabinet minister for higher education and innovation. Higher education, research and innovation. Research is important to the advancement of medicine. I'm sure many of you know. Without research, we would not have the possibility of developing new pharmaceuticals, new medical devices, new surgical procedures. And I'm sure, again, all of you know that again and again, it has been proven that those people who came up with more relevant ideas and sustained output of scientific publications have spent part of their training in research position. Not having a spell in laboratory research limits one's thinking, particularly when you are looking for a radical answer to a radical problem. Who are the clinical scientists? Talented, highly motivated, dedicated pediatricians or pediatric surgeons who not only possess excellent clinical skills, but also possess skills to apply the remarkable strength of modern biology and technology to the health care of children. Unfortunately, many countries don't have special clinical scientists because I think America is the only one country where you'll have a department, say for a department of pediatric surgery, Ann Arbor, take example Ann Arbor because I know it very well in Michigan. And they have, 22 pediatric surgeons, but there are 5 of them, their 70 to 80% work is research. But they are paid the same amount of money as the other who are doing only clinical work, and that's how you generate research. In Britain and Ireland also people have a protected time, 30% research, 70% clinical. And I think I was mentioning to Professor Srinivas, he has to do something like this if you want to, encourage worthwhile research in various disciplines. And you need a mentor for research. You need to be introduced, and a lot of people used to ask me for how long one should spend the time in research. I usually say at least 2 or more years so that you can initiate independent research. More importantly, that you are able to write research grants because there is no research without funding. Funding is vital. I was introduced, I was very lucky, very fortunate. I was introduced to research very early in my career. I started my MS in Maulana Azad, and in my first month I met this brilliant man, Professor Nigam, who developed retinal detachment when he was 41 and became completely blind at the age of 44. But he continued his surgical job as professor until he retired. He was a brilliant teacher. And when I started there, he had a project on liver transplantation funded by ICMR. And he asked me if I would like to get involved in this. And that was the start of my research. He taught me determination. Every Thursday evening from 6 to 8, I used to go to his house and read journals, 3 journals, Annals of Surgery, British Journal of Surgery, and SGO. Sometimes I'll read 150 pages. And to myself, I'll say, I thought I'd remember anything, but I must have remembered something. And in fact, my first paper ever was on liver transplantation. When he had this project, and I worked on that for 2 years with him. He unbelievable man. He would, even though he had no sight, he would stay in the experimental lab, keep asking you what we were doing. And in the evening at 8 p.m., he would come with his driver to, palpate the dog and so on. And I used to wake up at 2 in the morning to do the blood gases in these animals. I was so dedicated to this man. The other 2 people who influenced my career, the man in black the suit is Mr. Harold Nixon in Great Ormond Street, with whom I worked 2.5 years. And he would give me a Thursday off to go and work in the Professor Gabella's lab. He was a world-famous anatomist. And I learned electron microscopy in his lab. And the second year, I spent going to the lab of Professor Barbara Smith, who again was a world-famous in silver staining. And the man in white coat is Barry O'Donnell. When I went to work with him, he gave me a Tuesday off to work in the experimental lab on animals. As I said, you need a mentor. You need a start. Without that's difficult. And this is the building. This was the first research center, standalone research center on the campus of any hospital in Ireland, in the Children's Hospital. And I've spent nearly 45 years in this building, initially as a junior faculty, and then director of research for 20 years, and then president of the Research Institute. And I was the only pediatrician or pediatric surgeon ever appointed to as a member of the Health Research Board. That is a policy-making body of the government of Ireland on all medical research funding, decide where money should go. And these are the various areas of research that I have been involved, or my team has been involved. Experimental biological research. But the greatest highlight of my career has been working by side of these 82 pediatric surgeons who came from 18 countries. I had dozens and dozens of people who worked as senior registrars or registrars. But these 82 pediatric surgeons have been very special. They've been like my second family. And this is the the back wall of my office, and you can see, you can recognize this man here. As I said, I had many inquiries coming to people to come to work with me, but they were always clinical, except one. Professor Mitra once wrote to me asking if I would accept Srinivas as my research fellow. And that's the rest is history. As I said, they have been very special. Majority of them have come to do PhDs. And here you see the man in the gown is Professor Doi, is receiving his PhD from, and he's now a professor in Osaka. And all others, were also doing PhD. On your left here is now Fujiwara from Japan, who's a professor in Juntendo now. Next to her is a guy from Austria, Florian Friedmacher, and then Guzman, he's again a professor in Leipzig, and the man next there is from Poland, although he's decided not to stay. He's in Ireland now, he's a pediatric urologist. And that's Manuela Hunjiker, she's a pediatric urologist in Zurich. And Bali Kotasi is from Hungary, but now working as a pediatric urologist in Karolinska Institute in Stockholm. This is our, as I said, these 82 fellows have been a family to me. And this is our first reunion in Dublin in 2019. And we had another reunion in Stockholm in 24. But in this photograph, you see all those who are standing there, they're all now full professors. The two in front is Professor Thomas Wester in Karolinska Institute. He was the president of the European Association of Pediatric Surgeons. And the other guy is Udo Rolle, Professor Rolle, who is the president-elect of the European Association of Pediatric Surgeons. How did I, many times people will ask me, how did I come up with the idea of endoscopic treatment? When I was working with Mr. Nixon, he used to operate on Wednesdays. And next door, it was Sir D.I. Williams. Menu mentioned his name. He was the father of pediatric urologists in the Western world. He used to do his list on the next door, and I would go and see. And he would, every list, he will do two reimplantation of ureters. And he was a brilliant surgeon, but in the reimplantation, what they did was open the bladder and was just fixing the ureter to the bladder. Because the basic defect in vesicoureteral reflux is the absence of anchorage, because the ureter, when it approaches the bladder wall, it loses its circular muscle. Within the bladder, the ureter only have longitudinal muscle fibers. These longitudinal muscle fibers traverse distally, intermingle with the fibers of the opposite side, and get inserted into the trigone. That is the anchorage of the bladder. And in vesicoureteral reflux, in the primary reflux, there is congenital absence or deficiency of these fibers. So in other words, there is no anchorage, especially in grade 4 and 5. And what they do is, and that's how the tunnel become, submucosal tunnel becomes shorter. And the treatment, surgical treatment, was to fix the ureter to the trigone. And when I came to work with Barry O'Donnell, with the man in green, in the white coat, he was doing a reimplant every week. So I said to Barry O'Donnell, Mr. O'Donnell,
what we are doing is anchoring the bladder. Why don't we put in something under the ureter which will fix the ureter to the bladder? He said, good idea. So I wrote a grant and produced the reflux in the bladder by slitting the anterior wall in the piglet and treated it by intravascularly initially. And this was my, as you can see, reflux which will produce in the bladder. And then no reflux after injecting. And the urogram shows no obstruction. And we published these two papers simultaneously in the British Medical Journal on 7th of July, 1984. At this point, I should also tell, when you're doing research, don't get disappointed, because this paper, which was published in the British Medical Journal, I had sent it an abstract to the BAPS. All the pediatric surgeons know what BAPS is, British Association of Pediatric Surgeons, and they did not accept that abstract. And in fact, my paper was published before the meeting actually started, but they didn't accept the abstract. So sting, as we call it, had become was taken by a lot of people, started injecting. But the greatest paradigm shift which happened in the endoscopic treatment was the approval of the deflux as by FDA in 2001. With FDA approving this material, because some people were concerned about using Teflon, which was initially, before that I was doing, although it never caused any problems. But deflux was a biodegradable substance, and became, two things happened. One was the FDA approval, 2001, and in 2002, Journal of Urology published 50 articles in the century, in 1900, which had a major impact on patient care. And our paper, which was published in BMJ, was one of those classic articles. As Minu mentioned, it's a very simple technique. Any person who can do the cystoscopy can do the sting procedure. But single most important factor in relation to success or failure is the placement of the needle. As you can see, it should be at 6 o'clock position, and at the end you should have a nipple-like appearance of the ureteric orifice. As you can see here, grade 5 reflux again. And I hope this can work. There's a video. Not working. Okay, tell me the video is not working. No, not to worry. So this was our first 10-year follow-up patients, 1,551 patients, over 2,300 refluxing ureters. Quarter of them had evidence of renal scarring. And we were able, as you can see, the vast majority had grade 3 to 5 reflux. If we only inject in grade 2 if they have either recurrent urinary tract infections or evidence of scarring. There were only 4%. And that shows you in 87% we were able to stop the reflux after a single injection. Some of them needed a second, very few a third injection. And there were no adverse effects. And then a few years later, we published another study where we had a grade 4 and 5, 851 consecutive children, and 1,287 refluxing ureters. This is with the grade 4 and 5, and you can see here a third of patients had renal scarring, and again you'll see 70%. Menu made that point there, Menu Bajpai, that if even those who aren't, great proponents of open surgical, at least give a chance to 70% of the patients with even grade 4 and 5, you'll be able to stop the reflux after a single injection. But, that was the treatment, and that's another message for the young people here. When you get involved in a problem solving, there are a number of other ideas come. We had done something of the treatment, but there were a lot of questions still there. Why the disease differs in boys and girls? Why some patients develop reflux nephropathy, others do not? We have all seen a grade 5 reflux, normal kidneys, a grade 5 reflux, another child where the kidney is completely damaged. Can we predict which patient will develop reflux nephropathy and why the grade of VUR differs in affect the sibling? And we try to answer some of these questions. And this is a prospective Dublin familial study. In fact, we have the largest families in the world from one city. As you can see, 280 families, 325 siblings, and we have siblings. In fact, you'll see here, one family, we had 5 siblings. And our prevalence of VUR, this is a very strict prospective study, was 42%. I noticed you mentioned of 26%. This was 42% in our study. Our siblings were unique because we had siblings who had presented with a urinary tract infection and the siblings who had never had a urinary tract infection. And if you look at here, the incidence of renal scarring was identical in index patients and siblings who had urinary tract infections, whereas those patients who never had a urinary tract infection was only 15%. I must say here also, when we got an ethical approval, our ethical approval was we were screening siblings of under the age of 6 years of index patients who had grade 4, 5 reflux. That's what we got the ethical approval. And naturally, because we had such a large family, we have been involved for last many years of genetic studies, initially with linkage, but more recently with the new generations sequencing. And we have actually had some very regions of interest, especially in chromosome 2 and chromosome 10. And we published some important papers, which you can see here in relation to, including New England Journal of Medicine. So what is the current status of endoscopic treatment? We just published, Minu mentioned our paper. It was I was invited to write a review article by Nature Reviews, Disease Primers, and it was published in October. So I wrote there, and this was very well referenced, 250 references, 20-page review article. The introduction of endoscopic treatment of VUR in 1984 represented a groundbreaking shift from the traditional approach of observational management and ureteral reimplantation surgery. Over the years, extensive clinical outcome data from multiple studies have reinforced the long-term safety and efficacy of this technique. Today, endoscopic correction is the preferred first-line treatment for children with grade 3 to 5 primary VUR, as well as for complex cases in many institutions worldwide due to simplicity and effectiveness, certainly in the Western world and Japan, etc. This is the first line treatment. This minimally invasive 15-minute outpatient procedure has become an integral part of various treatment guidelines. Unlike long-term antimicrobial prophylaxis, it offers an immediate cure for VUR without relying on patient or parental compliance and can be easily repeated if necessary with a high subsequent success rate. What about future perspective? As we have seen from our family studies as well as from others, familial clustering and identification of numerous genetic, both in VUR imply that genetic factors are important in the pathogenesis of this condition. We are certainly convinced that we'll never find a single gene for this. It's a heterogeneous disease. You'll have genes for patients who have a reflux nephropathy, who do not have reflux nephropathy. Even in our patients, we have shown, especially in relation to gender, for instance, the incidence of duplex system in siblings who, in families where only the males were affected, was 16% compared to if only females were affected, or mixed male and female, it was less than 5%. So we believe in new developments in refined genomic scan techniques, and also initially when we started, it was very expensive. One genomic scan was costing us €1 million, but now they've become much cheaper, and I think because of that, it is going to be much easier in predicting the occurrence of VUR and understanding its pathogenesis, and could lead to improvement in accurate molecular genetic diagnosis as well as prognosis. More importantly, artificial intelligence and machine learning are gaining increasing popularity and credibility in pediatric urology, and as assisting in predicting surgical procedure outcomes and in demonstrating the severity of VUR by evaluating the and acquired imaging data. Furthermore, application of artificial intelligence should lead to considerable improvement in the individualization of the VUR diagnostics and therapy, and at the same time reduce healthcare costs. It also has the potential to find its place in guidelines of a patient, which patient is going to need surgical, which CAP, etc. As I mentioned earlier on, when you start a problem, there are a number of other sub-problems come. As you can see, this is our publication list only on VUR. I published more than 750 articles, but I'm just talking about only in VUR. And the most important factor is you'll see that majority of papers have been published on VUR in high impact journals. And therefore, I would like to say research is fun for its own sake, but occasionally one gets extra pleasure from seeing important applications and benefits, like it happens to us with the development of sting procedure. So while it is not delusional to think that investigations may improve mankind, most importantly, it is the challenge and stimulation of the true process that provides most gratification. And finally, I want to thank my VUR research team and various fellows and younger colleagues who have contributed to this. Once again, thank Professor Srinivas for inviting me. Thank you. Happy to answer any questions of anybody.
Thank you everybody for sitting through these talks. and the important talk of Professor Prem Puri. Now we'll start the felicitation. We were very grateful to our director, Professor Srinivas, to have given us this opportunity to call all our senior retired professors from the Department of Pediatrics and Pediatric Surgery. And we are very fortunate to have most of them with us. And the idea was that we should not forget our teachers and the seniors. And the idea is for the juniors to have a look at all these people, great people who worked in this institute. And you will be reading their articles, books all the time, but this is the time to actually meet them and see them. So we welcome all of them, and we would like to felicitate each one of them with this small function.
So it is truly a privilege to be among such dedicated and accomplished persons. So firstly, I'll like to call Dr. Srinivas sir and Dr. Sandeep Agrawala sir to felicitate Professor Prem Puri sir, who needs no introduction and has been a great inspiration for us all.
Well, thank you, Professor Puri. He said two things, other than the academic things, I had the key messages that, mentors are required. Sir, we are taking care. Called all of them to show our gratitude to all our mentors, number one. Second, you said an extended family. It's not a family of pediatric surgery. We extended to pediatrics. We are following you already. Thank you very much. Yes, we just wanted to share with you that this bronze medal, you got so many medals, but this is very near and dear to us. This is you, the teachers, and we are here on the shoulders of you. And we say that we, the AIIMS family, extend our heartfelt gratitude to all our teachers for your dedication and compassionate service that we shaped countless lives. As a teacher, sir, you stood as a pillar of knowledge and care, nurturing young minds with patience and still so rare. Upon your shoulders, we the students rose to learn and shine, carrying forward your legacy like a guiding sign. As a healer, now is a healer because these are the patients which are on your shoulders. As a healer, you gently mended tiny hearts and tender souls. In each child's fragile world, you helped make broken pieces whole. Your passion lit their paths through the nights of doubt and fear, shaping hope and health with hands that always drew them near. We bow in respect to all of the teachers. Your torch of excellence will forever preserve. Your guidance has built firm foundations, helping us stand tall today. Thank you very much.
Next, I would like to invite Dr. Meherban Singh sir on the stage. He joined as lecturer in Department of Pediatrics in 1968 and superannuated in 1997 as professor and head of Department of Pediatrics at AIIMS. I'd like to invite Professor Rajendra Srivastav sir on the stage, who joined as Senior Research Associate in April 1969 and rose to the ranks of a lecturer and assistant professor in 1970 and 1973 respectively. He superannuated as senior professor in July 1997. I cordially invite Professor Dilip Kumar Mitra, sir, who joined as MCH trainee in 1975 and superannuated in 2004 as professor and head of Department of Pediatric Surgery at AIIMS. I welcome you, sir. I humbly request Dr. Ved Prakash Chaudhary, sir, to kindly come on stage. He joined as MBBS graduate at AIIMS in 1967 and superannuated as professor and head of Department of Hematology at AIIMS. I cordially invite Dr. Professor P.S.N. Menon, sir, who joined as MD Pediatrics trainee in 1975 and superannuated as Professor of Pediatrics and consultant in charge of Department of Endocrinology and Genetic Division at AIIMS. I humbly request Professor Veena Kalra, ma'am, who joined as lecturer in 1974 and superannuated in 2008 as professor and head of Department of the Pediatrics at AIIMS. I cordially invite Dr. Narendra Kumar Arora, sir, who joined as MBBS graduate in 1971 and superannuated as faculty in Department of Pediatrics in 2007. I cordially invite. I
Whoever takes has to go to Melbourne. No, he's watching me.
I cordially invite Professor Vireshwar Bhatnagar, sir, who joined as MCH trainee in 1983 and superannuated in 2018 as professor and head of Department of Pediatric Surgery at AIIMS. I cordially invite Dr. Vinod Kumar Paul, sir, who is a member of Niti Aayog. Uh, it's my privilege to invite Professor Meenu Vajpayee, sir, who joined as MCS trainee in 1987 and superannuated in 2023 as Professor and Head of Department of Pediatric Surgery at AIIMS. I humbly request Professor Arvind Vaga, sir, who joined as MBBS graduate in 1976 and was the head of Department of Pediatrics from 2000 till 2023 and is currently an emeritus professor since October 2024. I cordially invite Professor Sushil K. Kabra, sir, who joined as SR in 1987 and became faculty in 1992 and superannuated in 2023 as Professor and Head of Department of Pediatrics at AIIMS. I humbly request Dr. Shinjini Bhatnagar, ma'am, who joined as house surgeon in Department of Gastroenterology in 1985, then joined at Department of Pediatrics as a scientist. She rose in ranks till she moved on to THSTI, from where she retired as a director a couple of years back. I'd like to invite Dr. Sandeep Agrawala, sir, who is our head of department.
Madam,
I cordially invite Dr. Pankaj Hari, sir, to kindly come on the stage. He is head of Department of Pediatrics currently. I cordially invite Dr. Sandeep Agrawala, sir, to kindly come on the stage, sir.
I think we are grateful to Professor Puri that, we have 5 generation of people, teacher, student is teacher, 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 5th generation of thing. I have the honor of the 5th generation fellow honoring the very next generation who was my teacher.
Now I would request Dr. Pankaj Hari, sir, to kindly come on the stage and give a vote of thanks for the audience.
So it's a proud privilege for me to deliver the vote of thanks. And I'm quite thankful to the Department of Pediatric Surgery for holding this update on VUR and felicitating all the ex-faculty members of the Department of Pediatrics and Pediatric Surgery. A very special thanks to all the ex-faculty members for making it convenient to be here and being present in the program. My extreme gratitude to Dr. Prem Puri for being the chief guest of the function for the update and delivering the talk. I'm also thankful to the Institute for providing all the logistics and to all the participants for participating in this update on VUR. Thank you very much.
So I'll invite you all for a very, very important and special opportunity to have a picture together. So we'll go out in the sun To the left side is the convergence block, and there are a very nice staircase where we can have a group photograph, which you all will cherish with all the senior people together. Thank you. And after that, we proceed for lunch.